to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs. Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotic site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zenat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotic site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zenat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotics is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zinat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotic site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zenat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotics site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zenat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Welcome, welcome, welcome. We're about to start, ladies and gentlemen. Okay. So I realize we have a quite robust online presence today. I would have you know that you're the privileged few because you're here. But online, we have close to 1,000 persons. So it's going to be a wonderful meeting. But first, let me welcome everyone collectively, those who are present and of course those who are online. My name is Nakia Rowe. I'm a Sandoz medical representative and I'll be your moderator for today. It's my esteemed pleasure to be your moderator. So I'd like to welcome you all here today for our Sandoz Health Summit. This is our second installation for the year, and this is in association in collaboration with Agpj. And we have representatives from Agpj here today, so I'll call them up shortly. Now, as you can see, we are over the moon with the attendance. We are ecstatic. We are very excited because it promises to be a very, very excellent meeting today. And so I'm also happy to welcome our colleagues from Sandoz. We have our first line manager, Mr. Christopher Beecher, who is here with us, and of course, some of my colleagues. Now, we also have from outside of Jamaica, we have a very, I would say, quite a very illustrious and very well represented crowd, all the way from Costa Rica. Our Sandoz, welcome them, our Sandoz commercial managers, product managers, and we also have our commercial manager, Mrs. Alisa Jaco, who is no stranger to us. We have somewhat adapted her. She knows that she's officially, you know, a Jamaican, so she loves to be here and we love to have her, right, Alisa? Of course, of course, of course. So, as I mentioned earlier, it's gonna be 4 speakers, and we will introduce them in proper time. But some housekeeping matters, especially for those who are here. We have coffee brunch outside, and we're gonna tell you when you can go. And also for the bathrooms, there's a main bathroom to the right of the table, at the front, where the main table, the main desk. So you can make your way there whenever you choose to, all right? We also have present with us, just scanning the room for those online. We have almost 40 persons in the room, so that's also a good number to welcome. So thank you for coming. So each speaker will be allotted at least 45 minutes to do their presentation, after which we will have question and answers. So for those in the audience, definitely we'll have a roaming mic so that you can go to the floor and ask your question, or of course, you can ask discreetly. Online, we also have the option for persons to ask questions, and my co-host around the back, Sam, will be reading me the questions for the doctors to answer. So we're looking forward to your questions as well. Now, we'll just jump right into the meeting with our first item on the agenda, and that is a prayer by no other than Miss Sana Pitkin-Kovo. Sana? Okay, Sana is a little bit delayed. So we'll ask Miss Christian Grignon Clark to come and do the prayers to open our meeting. Thank you.
Good morning, everyone. Let us pray. Most righteous and heavenly Father, we just say thanks. Thanks for yet again another day to be in the land of the living. Lord, as we are about to start today's proceedings, I pray that everything that's said today will be able to be retained, we'll learn and be able to expand our knowledge base when we go out and execute for our patients. Lord, I just want to say thanks again for the representatives online and both in person as well. We are truly grateful for the turnout. I pray that you'll just continue to be with us. In Christ's name we pray. Amen.
Thank you for that, Kristen. And now welcome the president of the Agpj, Dr. Donald Garden, to come and do his welcome and greeting. Dr. Garden, you're being summoned. Make him feel welcome again, please. Thank you.
Good morning. It's nice to be here and see so many faces I haven't seen in quite a while. Good morning, esteemed presenters, Sandoz Special Overseas team led by Tatiana, others, colleagues physically present, and to those online in the audience locally and throughout the region, the local Sandoz team members, moderators, chairpersons, Oldgate technical team who always make things go, the Agpj Secretariat, who is responsible for a lot of the planning, and the Agpj team members who are here to assist today. It is my honor and pleasure to bring greetings to you on behalf of the association and its members, to you, our valued guest, as we join Sandoz in hosting Health Summit 3. The topics in Health Summit 3 was deliberately chosen to cover the communicable diseases, NCDs, as well as the business of mental health, which has assumed overarching proportions in recent times in this stressful situation. It has always been our pleasure to work with the Sandoz team, and we welcome the new leadership of Sandoz team under its first line team manager, Mr. Christopher Beecher. Mr. Beecher, we're happy to work with you, sir. We are sure the relationship under your leadership will be just as effective and progressive as it was in the past. Sandoz and Agpj has had a long and unbroken relationship that goes back over a number of years. We are certainly looking forward to a continuation of this relationship in the future. It's a relationship that is built on trust, respect, and that one has been mutually beneficial to both parties. Sandoz has always been kind and generous and supportive of the association in the pursuit of its CME activities, and for that we are very grateful. The hosting of webinars and hybrid events such as these goes a far way to educate our members in the various topics which impact our daily practice as general practitioners. We are eagerly looking forward to the contents of today's meeting, as it promises to be a very interesting one based on the roster of distinguished speakers. In closing, we wish for a continuation of this mutually beneficial relationship between Sandoz and the association. And we are confident that today's meeting will be a very successful one, which will bring much credit to both organizations and the supporting cast. Finally, we thank you for giving us this opportunity to partner with your organization once more, and we certainly cherish these opportunities and relationships. Thank you very much.
Thank you so much, Dr. Donald Gordon. So right now we're gonna have our first speaker, and I'll call upon our more esteemed partner, colleague, Mr. Christian Freiter, to do the introduction of our very first speaker. Christian?
Thank you, Mr. Moderator. Good morning, guests here with us and online. It is my esteemed or distinct pleasure to introduce our first speaker, Dr. Kevin Harvey. Dr. Kevin Harvey is the Caribbean Regional Director of the AIDS Healthcare Foundation and is also a senior lecturer and head of the School of Public Health and Health Technology at the University of Technology. Dr. Harvey has enjoyed a distinguished academic and leadership career in medicine, public health, and infectious diseases. He graduated from the University of West Indies with a bachelor's in medicine, 1997, master's in public health in 2001, and furthered his postgraduate training with international degrees at some of the world's leading institutions. London School of Tropical Medicine and Hygiene, obtaining a diploma in infectious diseases in 2005, a Master of Science in the Control of Infectious Diseases in 2007 at the Hubert Humphrey Fellowship in Global Health and Control of HIV at the Rollins School of Public Health. That's Emory University, and that was in 2012. He later achieved the Doctor of Public Health from the University of the West Indies in 2015. He also obtained certification in managing people from the American Management Association in 2012. Dr. Harvey has held several prominent positions throughout his career, ascending the ranks of leadership in administration, public health, and control of infectious diseases, locally and regionally. His career started at the Kingston Regional Hospital, 1997. Then as District Medical Officer for the Buff Bay Health District in Portland. He later joined the Ministry of Health in 2002 and held the position of Director, Treatment, Care and Support, 2002 to 2008, Director of the National HIV Response, 2008 to 2013, Chief Medical Officer, 2013-2014, and Permanent Secretary, 2014-2016. He later joined the AIDS Healthcare Foundation as its Caribbean Regional Director in 2016, a position which he currently holds. That institution is actually an NGO, and it's located on Hagley Park Road. They actually provide free services to STI patients. Dr. Harvey has published several journal articles and has designed and implemented various programs, including the HIV/AIDS treatment program, the prevention of mother-to-child transmission of HIV programs for Jamaica over the last 7 years, and has also piloted the expansion of the AHF programs and presence across the Caribbean, particularly in Jamaica, Haiti, and the Dominican Republic. Dr. Harvey most recently has turned his attention to the training of public health students at the University of Technology and is also a Justice of the Peace for the parish of Kingston. He's also married with 3 children, some of which are in their 20s. But if you look at this man, he doesn't even have 1 gray. So we don't know how he does it all, but he's here with us today to share some of his wisdom and maybe some of his people management skills, which maybe he uses as a father. So let us welcome, give a round of applause for the distinguished Dr. Kevin Harvey.
Good morning, everyone. Good morning to those online as well. You know, I'm distinguished and I have to walk with my glasses. But when you listen to the introduction, it makes you wonder. So recently I've had to start growing my beard, you know, so that I can now look the part. But it's a pleasure to be here. I'm always happy to come out and give these talks. I've not been doing them a lot lately. Because as you heard, I work with a company called the AIDS Healthcare Foundation. And we're actually trying to pilot and expand and bring more attention to STI and HIV care across the Caribbean and the world. AHF is actually the largest provider of healthcare to HIV and STI patients worldwide. We have close to 2 million patients in our care, and we are now establishing clinics across the country. So instead of just working with governments to strengthen their programs, we're establishing standalone NGO clinics across the country. So we currently have one in Kingston, and we're looking to open a new one this year in St. Anne, and then the Montego Bay. 2 weeks ago, we opened our first clinic in the Dominican Republic, and we also have a clinic in Haiti, which I have not been able to visit in the last 2 years, but it's still functioning. So good morning, and today we are going to talk about the STIs and why they're still important. I'm not going to talk about HIV and syphilis and hepatitis. I think you all know the HIV pandemic is still ongoing after 42 years. And so we still say HIV is the other pandemic because everyone only remember COVID. But I'm going to focus my talk a little bit on the genital discharge syndrome, though I'm going to try my best to bring in some of the others. So, okay, I can't read that. So this is the disclaimer presentation from thing. So I'm going to give you a little overview of the STIs. I'm going to take you through syndromic management and take a look at some of the common STIs, and then we're going to look at the antibiotic regimes and then how to provide an STI service, and then we'll go into the discussion. One of the points I want to make is that though the STI syndromic management approach has been a strong and long-standing approach and still very relevant today, we have to now start considering shifting to diagnosis and etiological management of STIs because of where the world is going. And we're having several atypical STIs out there now that we have to focus on a little bit more in terms of diagnosis. So in terms of the impact of STIs, we have more than 1 million new cases each year and over 4.5 million HIV, STI deaths. This is the wrong presentation. So HIV, viral hepatitis, sexually transmitted infections collectively cause 2 to 3 million deaths each year and 1.5 million cases of new infections. I actually pulled some of the data from the Ministry of Health to see what we're seeing here in terms of genital discharge syndrome. And it was a little bit surprising that the numbers were so low, and I think we're not reporting and collecting them as we should. So this is a look at the syndromes reported to Ministry of Health over the from 2020 to 2022. And I pulled this maybe about 2-3 months ago to start looking at it. And you see that we are seeing, in the 3 years, we have seen about 112,000 patients, about 30,000 plus patients on average each year. But we noticed that in 2022, we have had a significant fall off in terms of the number of patients diagnosed in 2022. Maybe the reports are yet to come, but we're seeing only 15,000 cases for 2022, dropping from about 30,000 cases on average. But the striking thing about it is that when you look at the male-female ratio of the cases, you're seeing that the vast majority of the cases being managed in our system are from the females. And in fact, up to 81% of the cases are actually females that are diagnosed and treated in the government service. What is the reason for that? Males are less likely to turn up for care, but also the vast majority of STIs are asymptomatic. Up to 80% of the STIs can be asymptomatic, and hence they're out there undiagnosed because they're using syndromic approach, and the syndromic approach is challenged in terms of managing and diagnosing asymptomatic persons. When we took a look at the persons presenting to our AHF clinic, my clinic at Hagley Park Road, over the last 6 months, again, this is the distribution of what we're seeing. The vast majority still do get syndromic treatment, but we have an element of diagnosis in the mix, and we can see that we're seeing a lot of other things. So if you look at the blue line, it's ulcers, and I break down the STIs into two main categories: the ulcers, the warts, and the discharges, right? So the ulcers, like chancroid and syphilis ulcers, you can see only about 5% of the cases. Syndromic diagnosis is the majority. 60% of what we see are managed syndromically because of the cost to do testing. And syndromic management can provide you with good and secure diagnosis and treatment. However, we have found that maybe about 12% of the patients that we see recurring actually have some of the what we call the atypical STIs, like mycoplasma genitalium, and we are only discovering those when we are able to do some testing. So in this series that we have here, what's labeled as atypical STIs were in fact mycoplasma diagnosed. So these are what we're seeing in the STI clinics. A lot of BV. Syndromic management would include the gonorrhea, the trick, and the chlamydial cases to some extent. This is important because in women, you can have infertility, and that is the last thing you want to have. The fact is that sexually transmitted infections are disproportionately impacting younger persons, and that's when they're in their most fertile stage. And therefore, you know, the risk of infection, of infertility after one episode of PID is actually very high. And so in women, infertility, ectopic pregnancies, miscarriages, premature births, you know, mother-to-child transmission, particularly chlamydia. And in men, you can have the strictures, the epididymitis, prostatitis, proctitis, and all of these things. So what exactly are these sexually transmitted infections? Well, they're infections that are passed through sexual contact, very simple. And we have to remember now that sexual contact can be oral, vaginal, anal, or even skin to skin. And they can be viral, bacterial, protozoan, and parasites, right? Now, in managing these, there are four main ways that we can tackle these. The syndromic approach, which everyone knows and you use it daily. This is clinical, symptomatic assessment and treatment using your history and examination. And then you can have clinical, which is etiological based. You can diagnose herpes based on the look and the form. You can diagnose syphilis based on the ulcer type or chancroid, whether it's painful or not painful. And so you can make a clinical assessment. In syndromic management, you can practically treat from the history, which you really shouldn't, but you can. And then you have the etiologic, which is using lab isolation of the causative agent. And more, we have to start practice a mixed method where we're using the syndromic approach, but clinical assessment and mixed management. We should move away from just listening to a patient, oh, I have a discharge, you write a prescription, and that's it. You know, to make sure you move to the next step of doing a clinical examination, making a proper diagnosis, do a test if it is a recurrent problem at least, and then you move on to the appropriate treatment. And the Ministry of Health provides these algorithms in the standard STI management guideline. So basically, the point I'm making is that the management of the STI starts with establishing a diagnosis. And you can't just establish a diagnosis by the history alone. You should do a proper clinical examination and perhaps a blood test. So how can we make this diagnosis? The syndromic approach, yes, but we have to remember that 80% of the persons are in fact asymptomatic. So how are you going to reach these persons if we're not looking at doing some laboratory screening? And now we have FDA-approved point-of-care tests, rapid tests, that can be used to diagnose some of the STIs. And we also have the molecular testing platforms, which are good. So the syndromic approach was developed some time ago by WHO from in the 70s, and it was reviewed and adopted many times, pioneered in Jamaica. I always have to mention Dr. Brathwaite and Hilton Kong, who I had the pleasure of working with back in the days at the Ministry of Health. So the syndromic approach is pioneered in Jamaica and well established and ingrained. It is what we are taught in medical school, and most of us practice in our day-to-day practices. So it is very advantageous. It provides it particularly in rural areas where you don't have, and low income areas where you do not have laboratory access. It does provide early diagnosis and treatment based on signs and symptoms. And the syndromes are easily recognized, and there are only a few of the symptoms, really, if you think about it. And the treatment is given for the broad set of organisms that you expect, and it's usually simple, cost-effective, and it has been validated repeatedly. The syndromic management approach, however, is not as simple as we take it, and it's not just, oh, you have a discharge, here's a prescription for 3 different sets of drugs. But it requires you to take an adequate medical history and a good sexual history, because sometimes some of these presentations can be due to other things. You have to rule out some of the other more serious conditions, ectopic pregnancies, PID, other kinds of abdominal pelvic issues. So you should not just be prescribing treatment because someone comes in with a complaint of an STI. So you must do a complete STI clinical examination, and I keep reiterating that. And then the management guidelines and the algorithms are there, and the effective drugs, which I will go through. But I'm recommending that anyone who is having these recurrent problems, even after treatment, should have laboratory diagnosis. I know it's a little bit expensive, but we need to move towards that, and we should move towards having rapid testing mechanisms available in our private practices. I know most of us are not doing wet preps and microscopy in the office, but certainly you can actually establish and do some of the point of care rapid testings. And you know, in these broad, big, multi-specialist practices that we have nowadays, the labs can have molecular technology. The molecular technology is small and of such that you can actually start putting these laboratory tests closer to your offices, and you don't have to send away and wait days for the results. So when you compare the two, syndromic management is well established and is out there. The clients are treated on the first visit, which is important, but in the etiological treatment component where you have to send for a test, you may have to wait and treat the patients afterwards. And then the problem you have here is when you are talking about condom use and risk of transmission. So you still have to ensure that you have proper counseling sessions with the patient and ensure that you have they have access to condoms, etc. And you may have to treat while you have sent for the test, and when you get the results, you refine your management approach. But there's a lot of advocacy which needs to happen for this to occur, and I'm starting to ask you to ask that in your practices, in the government services, etc., we develop better capacities to diagnose the STIs. So what are these STIs of concerns that we're going to talk about this morning? I break them down into the sores or the ulcers and the leaks, which we're going to talk about in more detail. So the sores or the ulcers are like syphilis, genital herpes, and lymphogranuloma, chancroid, and granuloma inguinale. Some of these are less common. And for the ulcers, I use 2 main categories so that they're easy to manage. And those are so you have a ulcer, is it painful or painless? Is it multiple or is it single? And you can manage that kind of an algorithm. So the ones that are painful are chancroid, genital herpes, while painless ones would be syphilis, LGV, and granuloma inguinale. But as you know, I'm not going through all of these today. And these are what they look like, the kind of ulcers that you will see. Oops. Set me up back. Yeah, these are the kind of ulcers that you will see in that sphere. Sorry. So the leaks are the ones that we're going to talk about, and these are what you call the bread and butter of your private practice, literally, right? So gonorrhea, the chlamydia, the non-gonococcal urethritis, trichomonas, candidiasis, BV, and all of those are what we classify as the leaks. And then you have other major syndromes, which I'm not going to go into, like the HIV, hepatitis, the warts, etc. I'm not going to go into that. So let's take a deeper look at the genital discharge syndromes. So the genital discharge syndromes really are caused by one of these conditions here: gonorrhea, non-gonococcal urethritis, chlamydia, mucopurulent cervicitis, trick, bacterial vaginosis, mycoplasma, PID, or candidiasis. And so gonorrhea is most often talked about. And if you grew up in the era of Professor Bailey, for example, those days, you'd simply go and get black and red capsules and you'll solve your gonorrhea problem. I'm not saying that he did that, I'm just saying in his era. But that era shifted and we don't have that kind of flexibility anymore because of the resistance that the gonorrhea has developed to the penicillin-based antibiotics. So gonorrhea, commonly manifested by urethritis, cervicitis, proctitis, salpingitis, or pharyngitis, which we have to pay a lot more attention to in today's world. And you have to keep in mind also that the infection may be asymptomatic. So, and particularly in the vulnerable groups like males who have sex with males, you have to pay particular attention to pharyngitis, gonorrhea in the throat. So in the male, incubation, 1 to 14 days, dysuria, urethral discharge. You have to remember that it can be in the anus or the throat, and you can have significant complications. In the female, endocervical canal is a primary site, so if you don't do a speculum examination, you can miss it. 70 to 90% are also colonize the urethra, so you have dysuria frequency, as well as the discharge, and significant abdominal pain. This is what it looks like in the male. You can see the buttery looking kind of a discharge, a thick yellow discharge. Another version of the gonococcal urethritis. And then this is the gonococcal cervicitis, where you can see the thick yellow discharge at the entrance of the cervix. And it's, you do a cleaning before and you visualize the cervix and the os. Remember, you can also get abscesses, Bartholin's abscess, from gonorrhea. So we're going to come to the management, but just keep in mind that discharge and what it looks like in terms of the gonorrhea in the males and the females. So then you have the non-gonococcal urethritis, and most of these are related to chlamydia trachomatis. And now we're seeing an increase in the risk of genital mycoplasma or mycoplasma genitalium being present in these cases now of the non-gonococcal urethritis. So we have to now start thinking about non-gonococcal urethritis in the cases of these you have to now start thinking about genital mycoplasma genitalium in the presence of non-gonococcal urethritis, because it's not just chlamydia anymore. And the treatment is very, very, very different. And the symptoms are very similar though, mild dysuria, but the discharge is very different. And you can see that in this discharge, it's more clear, a little bit more milky, rather than yellow and buttery. So you have to be very clear about this. Sometimes you have to do milking to see the discharge, or you can ask the person to hold their urine and sit for 4 hours, and then you reevaluate if you're not seeing the discharge at the beginning. So this is the algorithm for managing the patients with urethral discharge. It's very simple, it's not complicated. It's basically what you have learned in school. Do a history, take the risk assessment, examine the patient, make a diagnosis, and then you treat. And if the treatment didn't work, you can examine the patient again. Did the patient not complete the medication? Do a test if necessary. Was it re-exposure? You retreat, or you refer the patient if you can't manage. But also remember now that I'm recommending that some of these patients who are returning get a laboratory diagnosis, so you can be very specific in terms of the antibiotics that you're choosing for the management of these patients. So you do your history and risk assessment. If there's a discharge seen, then it's an automatic treatment for gonorrhea and chlamydia once there's a discharge seen. And then you can follow up 7 days after, and to make sure that everything is cured. If the discharge is not cured, then you can treat for trichomonas. Some persons now will treat you for gonorrhea, chlamydia, and trich at the same time, but you have to remember that when you're giving someone azithromycin and metronidazole and doxy all together, it is not the easiest thing, and you may have to stagger or you start those medication together. So for uncomplicated gonorrhea, ceftriaxone 250 milligram IM stat is still the standard of care. Where you can use spectinomycin, kanamycin, or ciprofloxacin. But want to get into those, we want to as best as possible, use ceftriaxone 250 milligram IM stat. It is effective and still the drug of choice for gonorrhea. So that's what we use. If you have uncomplicated non-gonococcal urethritis, then you add doxycycline 100 milligram PO BID for 7 days. So even though I'm giving you these separately, someone with gonorrhea can also have chlamydia, and therefore you're actually mixing these things. So the person is going to get ceftriaxone plus doxy plus metronidazole potentially for the treatment of their syndrome. And this is why I'm saying you have to stagger the treatment or look at how you advise the patient, because these things are very harsh on your stomach and you're going to get nausea and vomiting and treatment failure. Plan your treatment regime properly. So try dox, ceftriaxone, ciproflox, and metronidazole, and have patient, and they're going to be able to tolerate all of that and go. So for the uncomplicated 100 BID for 7 days, you can use tetracycline, erythromycin if the patient is pregnant, or you can look at Oflox or azithromycin 1 gram PO stat. Let's take a little bit more, a deeper look at the vaginal discharges. Again, chlamydia, gonorrhea, genitalium, and then you have bacterial vaginosis, which is a very important thing that we have to pay attention to. Remember that bacterial vaginosis is due to the replacement of the normal lactobacilli flora with anaerobes, and therefore the treatment for bacterial vaginosis is going to be an anaerobe kind of regime with metronidazole, etc. And therefore, bacterial vaginosis is actually one of the most common causes of vaginal discharges in women. But if you use if you use the syndromic management approach, then you will realize that what you're doing is you're treating for gonorrhea, chlamydia, and trich. But you didn't necessarily, and if you add trich, but if you treated for gonorrhea and chlamydia, you would have missed the anaerobes from the bacterial vaginosis, and hence the patient keep coming back. You gave ceftriaxone, you gave doxy, you gave azithromycin, and the patient keep coming back because you didn't treat the anaerobes with clindamycin or metronidazole or any of those things. So you have to remember bacterial vaginosis is actually far more common than gonorrhea or chlamydia or some of the others things that you will see. So remember that. And bacterial vaginosis is also associated with an increased risk of PID, preterm labor, and may enhance HIV transmission. So you have to pay particular attention to that condition. So chlamydia is another major one that we talk about. Infection with chlamydia may result in urethritis, epididymitis. So I keep repeating the same thing because the majority of these syndromes affect the genital area, and you find that they all can spread and they can move up into the pelvis and end up causing PID. But as I'm saying, you also have to remember proctitis, and that the majority of these infections are often asymptomatic, and the chlamydia has the potential for transmission to the newborn through vertical transmission. There's a significant asymptomatic reservoir of chlamydia, and hence again my plea for diagnosis, because some persons are carrying these conditions for many months undiagnosed. And here you can see the mucopurulent cervicitis. It's a little different from the gonorrhea. As you can see, the extensive redness of the around the entrance, and you're not seeing that thick yellow discharge. So you have to take a look at the cervix in order to make some of these diagnoses. And then you have trichomoniasis. Everyone know the frothy, foul-smelling, fishy discharge of trich. But what we don't remember is that a lot of persons with trich has asymptomatic infection as well. And this is another thing that you can be carrying around for years. And again, the cervix is very important. You can see the strawberry cervix in the females. and the distinctive red dots in trichomonas infection. So men with trichomonas, also you have to remember, have symptoms of urethritis, epididymitis, or prostatitis. But again, up to 80% of these men have no symptoms. Mycoplasma, we have to remember this, causes symptomatic and asymptomatic urethritis among men and is the etiology of approximately 15 to 20% of non-gonococcal urethritis. So this is very significant now. When I did this a couple of years ago, I was talking about less than 15%. Now the studies are showing up to 20% and it's rising. So we can see that Mycoplasma genitalium is spreading and expanding, not just in Jamaica, but across the globe. And so it's responsible for 20 to 25% of non-chlamydial NGU and 40% of persistent or recurrent urethritis. So when we actually send patients, recurrent patients with recurrent discharge or recurrent complaints, even if the discharge is gone, they have dysuria, etc., and we send them to do the STI 9 panel, the vast majority that comes back positive, they're coming back as Mycoplasma genitalium. So we have to keep that in mind. And remember, among women, Mycoplasma can cause cervicitis, PID, preterm delivery, and spontaneous abortions, and also lead to infertility. So it's really something that we have to pay attention to. And as I said, it doesn't fit squarely into the syndromic management approach because the treatment is a little bit different due to some resistance. And so this is the discharge algorithm. And you can see for step one, take the history, especially the sexual history. And this is something we talk about a lot, that you need to talk about sexual history. Who are you having sex with? Are you using toys? What are you using, doing anal, vaginal, oral? All of these things you have to note. And as they are very important now in your sexual history. It's not just whether you're using condom or not anymore. And then you have the risk factor score. In this case, if you have a partner who has had a urethral discharge, then you get a score of 2, and therefore you should get treatment. Anyone with a risk score of greater than 2 should be treated. So just simply the fact that you had a partner who had a urethral discharge, it means that you are at risk. You could have asymptomatic infection and you should be treated. I'm not suggesting that you send home treatment for every person you diagnose in your office, but you should invite all the partners in to be evaluated, and you should prescribe treatment for someone who has had a partner with a urethral discharge. And then if you're a young person with a new partner, that's also a risk score for treatment. And if you have had 2 or more partners in the last 3 years, you also end up getting 3 months, you also end up getting treatment. So remember my bimanual pelvic exam and pass the speculum. These are things that we know. Clean and inspect the cervix and observe the nature of the vaginal discharge. And then based on what you see, you treat. But inevitably, you're ending up treating for gonorrhea, chlamydia, and trick because you can't differentiate in the majority of times. And so the treatment for trichomoniasis is metronidazole or tinidazole, 2 gram P-O-stat for acute cases and contacts. Metronidazole or tinidazole, 500 milligram, 5 to 7 days, depending on chronicity. And in pregnancy, you can use clotrimazole vaginal tabs or cream in the first trimester. Now, this is what I'm saying. It is not easy to tolerate 2 grams of metronidazole. And if you give that person another 1 gram of azithromycin or 2 grams of azithromycin to take on the same day, it is going to be problematic. And then you say also start some doxy 1 twice a day. It is. So my recommendation is that you can start the stat dose today if you're given metronidazole, and then the next day you can start the azithromycin and you just phase them all in rather than trying, because it never works. They always come back with stomach irritation and problems. For bacterial vaginosis, again, remember this is very important because you're treating anaerobes. So you need to use metronidazole, 500 milligram BID for 5 to 7 days, or clindamycin, or you can remember that you can use the trichomonas regime sometimes. And candida, you have Clotrimazole, 200 milligram. We all know how to manage the candida complete component. But for chlamydia, it's doxy, 100 milligram BID. You can use tetracycline or erythromycin. Gonorrhea we discussed already, ceftriaxone, 250 milligram. And I'm not going to go into the herpes and HIV. But this is where I wanted to take you, because the treatment of mycoplasma is a little different. And I'm saying mycoplasma is going up 15 to 20% of those, 15 to 20% of most of the syndromes that we're seeing now, of the discharges. So the recommended treatment by CDC is a sequential two-step therapy with doxycycline followed by an additional agent, which is usually azithromycin or moxifloxacin. Because resistance to azithromycin has been rapidly increasing in Mycoplasma genitalium and has been confirmed in multiple studies over the world. And I don't think there's a specific study in Jamaica, but I'm sure it is the same. And the prevalence of molecular markers for macrolide resistance can be up 44 to 90% in some of these countries that have done the studies in the United States, Canada, Western Europe. And you know, we tend to model the US and some parts of Europe in terms of our disease profiles. So the treatment for mycoplasma, if macrolide sensitive, and most times you're not going to know, so this is what you're going to start with. Doxycycline, 100 milligram twice a day for 7 days, followed by azithromycin, 1 gram orally initial dose, with 500 milligram orally once daily for 3 additional days. So this is the regime. And you can see it's a little different from your regular syndromic management approach. And then if macrolide resistance, you still use the doxy, but you have to replace the azithromycin with moxifloxacin, 400 milligram, once daily for 7 days. So if you're not able to tell and you can't check, it might be best now for us to start moving to a standardized regime of doxycycline and moxifloxacin rather than trying to try the azithromycin to see what happens. And finally, I'll give you a quick look at PID, which is a very important syndrome and is the result of poor management or untreated STI complications. So this is where we end up if we're not diagnosing early and treating. And as I said, remember that 80% are asymptomatic. So these persons could be sitting for years with chlamydia and trich and don't know, and hence can end up with presenting with first presentation with pelvic pain and hence PID. So PID is really a clinical syndrome resulting from this ascending spread of microorganisms from the vagina and endocervix to the endometrium, fallopian tubes, and our contiguous structures. In a female, and it has to be in a female, who has lower abdominal pain and who has not been diagnosed as having an established cause. So if someone presents with pelvic pain, you have to rule out all the more serious conditions first, like ectopic pregnancies, acute appendicitis, functional pain, all of these things before you jump to PID. But in order to diagnose PID, there's a specific criteria that we use to do it. And the CDC criteria is very clear. So if you have one or more of these plus some of the others, so low abdominal tenderness, or tenderness with motion of the cervix, or cervical motion tenderness, or adnexial tenderness. So if you have any one of these plus any of the following, then you can make a diagnosis of pelvic inflammatory disease. So at least of the following findings, so it meets the surveillance case definition, so chlamydia, exposure, or partner with gonorrhea. So you have cervical motion tenderness, low abdominal pain, and you have a partner who have had gonorrhea or treated for gonorrhea or chlamydia. You know that that person is likely to have PID. The temperature is elevated, PID, high white cell count, purulent material in the peritoneal cavity obtained by cholecentesis or laparoscopy, pelvic abscess or inflammatory complex detected by bimanual examination or by sonography, and the patient is a sexual contact of a person who's known to have gonorrhea, chlamydia, etc. So if you have abdominal pain, pelvic pain, you have cervical motion tenderness, your temperature is elevated above 38, or you have material from, you have a partner who has had urethritis treatment, etc., then that person more than likely has PID, and you're going to treat for PID. Again, mycoplasma is featuring in PID, and we're seeing that 4 to 20% of the cases of PID is now coming from Mycoplasma genitalium. So we now have to start focusing on this a little bit more because it is now featuring a lot in PID. So just treating for gonorrhea, chlamydia, and trick is not cutting it anymore. You have to remember PID. And this is the algorithm for the management of low abdominal pain. One of the critical things to remember is that you should refer the patients if you're not getting success, because it could be an ectopic, it could be appendicitis, it could be various other things. So if you're not sure and very clear that you're making a diagnosis of PID, then you need to be doing some ultrasound and referral to gynae, etc., for further evaluation. And basically the treatment is, again, treating the organisms. So ceftriaxone with doxycycline, you reevaluate, and if necessary, you're going to add metronidazole. So basically the algorithm speaks to the treatment of gonorrhea, chlamydia, and trick. But I'm saying nowadays, if you're finding that you're having challenges with this algorithm, you need to apply the Mycoplasma genitalium treatment regime to persons with PID, because up to 20% of them can be mycoplasma. So those are the main STIs in terms of the genital discharge syndromes. But what I find is that most of us will know what antibiotics to apply. We sometimes are, very quick to prescribe antibiotics. We move these persons through quickly. So I wanted to speak a little bit about service orientation in trying to facilitate treatment and encouraging the other 80% of persons who are asymptomatic but exposed to visit us, get an assessment, get a test if necessary, and get treatment for their STIs, because we need to reduce this massive reservoir of untreated, undiagnosed STI that is out there. So from our perspective as an NGO, we propose that services should be free. So we know that in the government service, the STI clinics are free, but we need a little bit more, because as you can see, most of the men are not going to the government clinics because 80% of their clients are women. And I can't believe that 80% of the women are having sex with women. So the men who they're having sex with are out there untreated, untested, or maybe they're in the private sector, but I'm not clear that that is actually so. So, and even in our clinic, you could see that the vast majority of the people that we see in our clinic are also still women, despite the fact that it is closer to 60% women than the 80% in the government service. So we are advocating that we need to make our services more friendly and to be able to attract walk-in patients with no appointment necessary. Somebody can just walk in and get treatment for their STI and walk out. And we are also advocating that we use more technology, point of care testing, have access to laboratory tests and the rapid tests which are available for these conditions now. And you can also set up and do wet preps and go back to that old kind of standard. So in closing, I want to introduce you all to our clinic. The HF Medical Center is at 183 Hagley Park Road currently. We have been there for 5 years, and for the first 2 years we had to tolerate the fixing of Hagley Park Road, so we had no patients. But we have grown significantly. I think we have 2 full-time doctors, nurses, social workers, case managers, everyone that you can think of. Right now, we manage over 400 HIV patients in the clinic, plus we have thousands, literally, of STI clients that pass through. And the clinic provides free diagnosis and treatment. So even if you're a recurrent patient and you have to do an STI-9 panel, after being treated and come back, we'll pay for the panel to have it done for you, because we make sure you're completely cured. And all the STI drugs are free and available on the same site. and the testing is free as well. We do point of care for many things. So we have a pharmacy on location. So once you're diagnosed, you get your prescription, you go to the pharmacy, and you get your medication all for free right there. And the lab is also on site. If we have to take samples, we do it as well. And just to say that this week, we got approval last week. We've been working on it. But come next month, we are planning to open HF Otrius at the White River Plaza in Otrius. And that is a tremendous thing. So this is some of our material. Yeah, you can clap. So you can go to our website and you can see all of this, hfmedicalcenter.org. You can go to our Facebook page, or you can go to our Instagram. We do a lot of this on site, on social media. So we have a lot of campaigns that we run from time to time to encourage persons to come in and get tested. We are open 9 a.m. to 5 p.m. Monday to Friday. And so this was one, you all remember the Burna Boy concert that was here? When Burna Boy was here, we put this up. So your STI burning you, and you spent your last. You remember that song? Yeah, so we say if you spend, you can come to us and get your treatment for free. So after these events, carnival, the major concerts, major holiday events, etc., we see all of those people coming. You think you have an STI? So these are some of the things that we use in social media to try and bring people in to get tested. So in that, I will stop. Thank you very much.
Give him another round of applause. Wonderful presentation. Nakia, over to you.
Thank you so much, Dr. Harvey. That was indeed a very excellent presentation with so much information. I hope you're all awake now. So we started off with a bang, right? You can all agree. So we're going to field some questions to Dr. Harvey. And Christian and my colleagues will be actually going around the room, and you can come to the floor and ask your questions. So please feel free.
All right. So let's take one online before we go to Prof, as the screen's changing. The first one we have here online for you, Doc, is this presentation seems to imply that the MOHW target of eliminating syphilis is probably going to fail. Any comments?
Well, I didn't mention syphilis in the presentation, but the MOH is actually far advanced in the elimination of HIV and syphilis among pregnant women, etc. But syphilis is out of control, and the prevalence of syphilis is very high. All of you should be doing rapid testing for HIV and syphilis and penicillin treatment. Syphilis among the general population is high.
Okay, thank you very much. Prof. Bailey?
Okay, thank you very much. Dr. Harvey, thanks for a very comprehensive presentation. I want to stimulate your mind a bit. I have been challenged in my own practice with persons opted for complementary treatment for vaginal discharges, like ginger and boric acid and other strange and wonderful preparations. What advice would you want to give them?
Yeah, so a very popular one now is noni pearl.
Oh dear.
Yeah, and so I've had to remove a lot of these when they're caked up and.
What on earth is that?
Noni pearl?
Yes.
It's something to cleanse the vagina and give it a nice sweet smelling taste and smell.
Oh dear.
Yeah. So there are lots of these alternative practices, but I don't subscribe, I don't encourage any of that. So I encourage my patients not to do that and to get treatment. Remember too that some of these persons will have in IUCDs, and you have to pay attention to that when you're doing your treatment. If PID, you may have to remove the IUCD. It's recommended that you at least start treatment first, and then you remove the IUCD a couple of days after, but no to the complementary inserts.
Okay, thanks much. I have another thought I want to share with you. It has to do with bacterial vaginosis. We know that oftentimes these persons have fairly abnormal pH levels.
Right.
And one of the concerns I have has to do with frequency of sex. And presence of bacterial vaginosis, especially since we do know that semen is alkaline. And I've oftentimes told patients that daily sex might not be such a good idea, that perhaps you need to give your vagina some time to recover. What are your thoughts?
So if the pH goes up above 4.5% in the female, then there's a risk of greater invasion, removal of the lactobacilli and others, and greater invasion of the abnormal floral. It's very hard to tell the women not to have sex every day. Yeah, but what it is that if you and the thing is, having different partners, that is going to increase your risk of exposure to different kinds of different kinds of bacteria. So if you're having multiple partners, then that's a problem. But if you and your partner both have been treated, tested, and are clear, then you should have sex as much as you like.
One more from online. It's Dr. Harvey. You said 250 mg IM stat ceftriaxone for uncomplicated gonorrhea. Don't you recommend the increase to 500 IM as the CDC has stated?
Right. So some persons use the 500. In Jamaica, we still recommend the 250. I will tell you some tales out of school. I know the university hinted to me that they've just done a study too with looking at gonorrhea, and they're not seeing the level of resistance here that are outside. And so 250 works very well for gonorrhea here. I know in the US they're using 500.
Peter Soyibo from Apex. Excellent presentation, Kevin. Really enjoyed it. Syphilis. We have a real problem getting benzothine penicillin. What is the status of it in Jamaica?
It's a challenge. The last time we had to import some from China, but I think it's now available at NHF, and you can buy it directly from there. If you have a challenge, you could link me. Maybe we could facilitate you through our pharmacy at AHF. I know we have had to give to other NGOs and we have donated to the government as well. But in fact, this month, we're in partnership with PAO, we're sending 6,000 doses of penicillin to Cuba for the treatment for their program, because they're having challenges getting penicillin as well. It's a worldwide problem with the benzothine penicillin, but we can get it out of Mexico and out of China, and I know NHF had sourced some supplies and they should have it now.
Yeah, I don't know, Sandoz used to bring it in. I don't know why they stopped, but I don't know if any of the team members have any answer to that. Back to the subject of bacterial vaginosis. It seems to be one of the most commonest affliction, and it's very embarrassing for the females. And we are seeing patients who are not even sexually active are experiencing BV, and what they're asking for is something to rebalance their vaginal pH. What do you recommend? Because they're not having sex and yet they're still coming up with these issues.
Yeah, so you can take the probiotics. It helps to rebalance your gut and vaginal flora and all of that. So they're available as gummy bears, as liquids, as powders. So we recommend that you can use probiotics to rebalance in those females.
Thanks so much. I depend heavily on the PCR STI9 panel to check for or diagnose STIs. How accurate is it?
It's fairly accurate. It's using PCR technology. PCR technology is tremendous. The challenge you have is how you collect your sample. And sometimes if you're not using the appropriate sample, then you might have problems. Because if you're sending a swab, for example, and you didn't swab properly, then you might have challenges. But the technology itself is fabulous. And it's very simple. Now you can have small machines, you can build out platforms, you can use the Gene Expert or several of them that are out there now that really gives you good results.
Thank you. A bit of a case here. A patient was found to be Mycoplasma plus positive while doing a routine STI9 panel screen. It was completely asymptomatic, and I prescribed 1 gram P-O-stat of azithromycin. How would one know if she has cleared the infection? Do you think she was undertreated?
Yeah, so she likely didn't clear the infection, and she was undertreated because remember the treatment for mycoplasma is doxycycline, 100 milligrams for 7 days, and then we're saying add moxiflox or azithromycin. And in fact, I'm recommending that we're trying to start shifting away from azithromycin and use moxiflox as the preferred.
All right, I think we have a few more. This one, you spoke about the effects of the combination of doxycycline, Flagyl, and Rocephin stat doses. Is there a drug the patient can take as a prophylaxis to counteract the side effects?
Well, it's very difficult. You can give gravel and antacids and Pizol and all of these things, but it's harsh. I wouldn't do it. It's because you'd have to be taking those a couple of days before. It's not going to work because you're treating on the same day. So I can't think of it. I think it's better to stagger it. Don't give the patient metronidazole and azithromycin 2 grams each at the same time plus doxycycline.
All right, everyone, again, please give Doc a wonderful round of applause. Thank you so much.
So guys, we are moving quite well as it relates to time. So again, thank you, Dr. Harvey, for that wonderful presentation. So I know some of us kind of came here early and perhaps didn't get, your breakfast. So thanks to Sandoz, we are providing a coffee break. And sorry for the online folks. I know you're at home chilling, so you're having a wonderful time as well. So we're gonna break for 10 minutes to allow you to grab something. If you see the time running, you can come back in and you can have it here. So we're gonna break for online. So we start back in approximately 10 minutes, so that would be 10 past 10. Thank you.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zenat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotics site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zenat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotic site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zinat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotic site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundal facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundal. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding
for rejoining. So, of course, we'll move right along. But first, let me, for those who are just joining us for the very first time online, let me just again welcome you to our Sandoz Summit in association with Agpj. But today, as you can see, on my backdrop, we have our Zinat. And this also doubles as our Zinat relaunch for Sandoz, because for those who are not aware, Sandoz is now the very proud, and very passionate owner of this brand. So it was a little bit off the market, but it is back in full force. So feel free to continue to support this brand. And of course, Sandoz will take very, very good care of this brand, and you will be seeing us out there in the field and telling you more about the Zinat. So thanks again for rejoining us. And we'll now have Ms. Sashane Francis, who will do the introduction of our next presenter. Welcome, Sashane.
Thank you, Nakio. Good morning, ladies and gentlemen. I am so pleased to be with you this morning and to have the chance to introduce our speaker, Dr. Adedamola Soyibo. Dr. Soyibo comes to us with a great depth of experience and knowledge in his field. He has spent close to 20 years serving in diverse roles ranging from medical officer of health at Sentence Bay Hospital to senior lecturer, consultant, internist, and consultant nephrologist in the Department of Medicine at the University Hospital of the West Indies. Though medicine is a passion of his, Dr. Soyibo is quite the writer as well, contributing more than 25 full paper publications in peer-reviewed journals such as Kidney International and the West Indies Medical Journal. Though he contributes so much to the medical field in this fashion, he has also managed to perform the duties of assistant editor for the West Indian Medical Journal for over 12 years. He continues to make his mark within his chosen field of nephrology, a real-life kidney superhero, so to speak. He serves as Chief of Nephrology in the section of nephrology, hypertension, and renal transplant, head of the organ transplant unit at the University Hospital of the West Indies, and a technical director at the Caribbean Institute of Nephrology. He has also served as chief coordinator of the Jamaica Renal Week Symposium and assistant chief coordinator for the annual conference of nephrology and hypertension between 2008 and 2014. Dr. Soyibo would take the knowledge and experiences gained and in true philanthropic fashion would cross our Caribbean waters to be the founder and coordinator of the Tobago World Kidney Day in 2011. Philanthropy is a common denominator in Dr. Soyibo's professional career. His brainchild, The SciArc, and that's SY-ARK, Research Institute, a Jamaican nonprofit charity, has been providing medical philanthropy for those in need for over 5 years. Dr. Soyibo, a true scholar, has disseminated the education he has gained with great benevolence. His boundless knowledge base and wide range of world-class experience, as well as having academic training responsibilities since 2009, has made him a master in delivering workshops and seminar presentations. And he has indeed been a staple at CMEs since 2011. It is safe to say that Dr. Soyibo comes to us well-versed in all things renal. However, I wouldn't attempt to test him on basketball. He is also an acclaimed sportsman and has received Outstanding Achievement Awards for basketball in 1997 and 1998. Without further ado, please join me in welcoming our speaker this morning as he presents on the topic, Lipid Management, Guidelines for Adults with Chronic Kidney Disease. Thank you.
Thank you for your over-exaggerated introduction, but yeah, I don't think mine was as long as Harvey. I think next time we should do this in a PowerPoint presentation. I don't know. I always insist on 2 lines, a name and which high school I went to. You know, that's the most important part. All right, so we're gonna move from chronic communicable disease to chronic non-communicable disease. And no, we're not talking about diabetes. No, we're not talking about hypertension. We're talking about lipids, and that's my disclaimer. And also they should add that I do not speak Spanish very well, so just for you to know. So this is what I intend to go through in the next 35 minutes or so. So the nexus between CKD and cardiovascular disease, you know, why do persons with chronic kidney disease die? And this is probably one of the reasons why a lot of you also try to avoid them. Oh, you have renal failure, I can't manage you, send you off. I hope they do manage them when they have STIs, because I looked at all those antibiotics, apart from levofloxacin, you don't need to renally adjust the dose for most of them, apart from levofloxacin, so you should be safe. What's the effect of CKD? I mean, how does CKD really affect lipid metabolism that puts these guys at risk? So pathophysiology, and for those who are online, if you're a medical resident, or if you're studying for any kind of exam, then you probably might want to pay attention, but then for everybody else here, just go with the flow. And then we talk about really what is lipid management, and you'd be surprised what the guideline out there suggests. You know, 2 lines and everybody's out of here. And then what drug can we really use in lipid management in persons with CKD? So, well, I like to show this slide because we need to know that what we're talking about is not just the US, but Jamaica. So if you look way at the bottom, you see that the incidence of high cholesterol is 12%, higher in female compared to male. And if you look at the treatment of those persons, it's just 11.6% of persons actually on treatment for lipids. And we're achieving good control, probably one of the better ones in terms of the chronic non-communicable diseases. And when you fast forward to the current, cholesterol levels has gone up 18%, much higher in female compared to male, but I think male actually went up higher compared to women. And then in terms of control, it's still abysmal. So for those of you who has been to any presentation I did the last time, you will have seen this one, but this is pretty new. This is a picture I took while I was in Italy. And so I had to ask question about, you know, everybody knows Michelangelo, and everybody has seen this picture, but we're not really sure what's the name of it. But I put this there just to illustrate what I call the spaghetti effect. And basically what's happening is every single one of us, we can look at the way we were probably 20 years ago and see what our metabolism is like, our physical structure. And if you were to do your lipids also, then, and you can monitor your own lipids over time, you will see changes, lipids, HbA1c, blood pressure, all those. And this is what has happened to Michelangelo painting as time goes by. So, which means we need to figure out a way when we get to a certain age to start to sort of reverse the process. So just a quick thing, what is chronic kidney disease? What is chronic kidney disease? We know it's an abnormality in the structure or the function of the kidney. And the key point being, we know about the function because everybody looks at GFR, but a lot of people don't pay attention to what we call the structure. You know, if you have a single kidney, if you have a horseshoe kidney, if you have polycystic kidneys, if you have sickle cell affecting your kidney, you know, there are other structural abnormalities that you can think about that predispose you to chronic kidney disease. And the idea is when you have these problems, either you have a reducing GFR or sometimes you might have a super abnormal GFR, which is hyperfiltration. And then of course for the function, we're talking not just the presence of protein or blood, but you can have other disease process, you know, like, you know, wasting of potassium or inability to handle acid. And all of this constitute to kidney damage. But also what we need to understand is that this has implication for your health or for the patient's health. So we need to remember that. CGA is what we're using now. And when I say now for the past 7 years, that everybody who has a CKD should have a cause. You need to know what's the cause of the CKD because we need to manage that disease process that is causing the CKD itself. Then we need to put them in the GFR category, which is what you will get in your lab when you do, you know, lab investigations and you get that GFR reading, because category also matters in terms of what stage is the patient on. If you're a G1, G2, G3, G4, G5, it has implication for drug management, and it has implication for dosing management, and also the type of complication that you're going to start seeing. Because somebody who has a G1 CKD may not have the same level of complication as somebody who has G4 stage kidney disease. And then lastly, we need to look at the albuminuria category, because albuminuria, believe it or not, is a mark of endothelial dysfunction, which is one of the hallmark of cardiovascular risk. So this is what was put out in 2012. And basically what this is showing you is just to give you an idea of cardiovascular risk factors for your patient. So the green line is those who have low risk. Okay, so as you can see, low risk means those persons who do not have albumin that is greater than 30, and who basically has a GFR of G1 to G2 when their GFR is greater than 60. Those are the persons with low risk, but they still have CKD, and they still have a higher risk compared to the rest of the population. So we have to understand why this nomenclature is important, because now we can understand their risk factor. Well, you know, this is the Caribbean, and this is what we're seeing in terms of causes of chronic kidney disease. And basically, you can just, you know, shift the first three in different order, depending on which country, which Caribbean country you're at. But the first two is really the most important in terms of diabetes or high blood pressure, and it just changes from which Caribbean country you're coming from. Now, I put this there because it's important to understand the cardiovascular risk factor of chronic kidney disease when you compare it to like cancers. And as you can see, our patient with end-stage renal disease on hemodialysis have reduced survival if you compare to those persons who've gotten kidney transplant. So we do advocate that if you have chronic kidney disease, end-stage renal disease, you should, if it's possible, get a renal transplantation. But as you can see, some of those persons with end-stage renal disease on hemodialysis have a reduced lifespan compared to some other malignancies, as you can see on the far right. So chronic kidney disease does put people at increased risk for death. Unfortunately, the diagnosis still remains low. 1 out of 7 persons who should be diagnosed with CKD, it's only the person that is the 1 out of 7 is actually being diagnosed, so we're missing out the rest of the persons based on their medical records. And this is a spin-off that I use for my patients sometimes, just to give them hope and to look at CKD and when it comes to dialysis as in a different way. Because if you do make it to end-stage renal disease, that means you will have survived cardiovascular risk factors. You haven't died from any of those, because not everybody with CKD will actually get to end-stage renal disease to need dialysis. They will die of cardiovascular risk. So it's important that you yourself, as a managing physician and who might be interacting with them, understands that. And the cause for cardiovascular event actually changes based on what stage. So you can have cardiovascular event, or you can have death from cancer and infection. So to summarize just what I've said, CKD is a burden by itself and is significant, and leading cause of morbidity and mortality is still cardiovascular disease. Primarily, you need to think about the atherosclerosis, coronary disease, and then it changes later on. Also, the risk factor for cardiovascular disease also includes CKD. So CKD gives you cardiovascular disease. A risk factor for CKD cardiovascular disease is CKD, although this is not widely accepted as yet up to 2018 guidelines stipulation. Some people consider chronic kidney disease as a cardiovascular risk enhancer as opposed to a cardiovascular risk itself. But it's just a matter of time that we get a randomized trial that actually, proves that. And that has to do with the fact that treatment is set not to be effective in persons who have end-stage renal disease, but I will explain that a little bit later on. Regardless of the cause of CKD, patients have increased risk, so we need to understand that. And therefore, it is considered that you should think of these people as having highest risk, regardless of their level of traditional risk factors that we know of. Okay, so what's the effect of lipids? What's the effect of CKD? So this is a nice diagram, for those persons during medical school, if you still remember your cardiorenal syndrome. But basically, there's a crosstalk between the heart and the kidney. And the events that happens in the heart also affects the kidney, just like how it affects the brain. So in terms of perfusion, and the kidney will respond to such by stimulation of your renin-angiotensin-aldosterone system, which unfortunately is not good for the heart, because now you increase your sympathetic tone. So perfusion, your blood pressure goes up, and then the heart has to do more. Then you end up with left ventricular hypertrophy, and left ventricular hypertrophy, you end up with left ventricular dilatation. And as you can see, problem starts, then you develop heart failure. Then it goes downhill. The kidney is not perfused, kidney senses that is happening, increases your tone. So you set up a vicious cycle between, the kidney and the heart. And we need to think about this so we can mitigate against it. So this slide really, well, I can't point, but this slide, if you look at the risk of, of death or risk of cardiovascular disease, when you look at the top part, you will see non-atherosclerosis, cardiovascular disease, you see left ventricular hypertrophy, you see arrhythmias, you see sudden cardiac death, arterial calcification, hemorrhagic stroke, and others as being the more common cause of death. And these are not amenable to your regular statin or coronary angiogram or ACS protocol that you're used to. because then at that stage, there are other things that are compelling or competing cause of death. And then infection also becomes another important factor. So if you think about it, so if you use the measures to mitigate against atherosclerosis, it will work up to a certain point, and then once the patient lives long enough, other reasons for death, like arrhythmias, like they get shift in potassium, they have increased calcium and phosphate product, and that all of that can lead to a different cause of death in this person. So I put this slide there because I want the primary care physicians, what is your role in atherosclerosis cardiovascular disease? And what you need to think about is the fact that patients who have CKD have been shown to have similar rates of myocardial infarction, or they have coronary artery disease. And when you compare it to those persons who have diabetes, we all accept that diabetes is a cardiovascular risk factor. If you have diabetes, you should consider the person as having a myocardial infarction, and you should at least address them in that way. So we're saying to look at chronic kidney disease in the same light based on the evidence that is available. And even though there are several studies, or even though the patients with CKD, should be considered as part of the highest group for cardiovascular disease, these patients are often underdiagnosed because with different reasons why patients are not managed for CKD, or why statin is not used in this patient. But the recommendation is we need to consider using, cholesterol lowering agent in this patient. Also, what you need to consider is there are multiple factors. So like your GFR, the presence of diabetes or hypertension or other comorbid conditions that will increase your cardiovascular risk. Albuminuria. So I will show you a slide that looks at albuminuria severity and cardiovascular risk. Nutritional status of the patient, it's very important to pay attention to that, and the use of other medications that can constitute to increased risk. So we need to make sure we consider that. And then lastly, for the role of primary care, in people with chronic kidney disease, it's important that you have at the back of your mind that as the kidney function reduces, in you that this person is in cardiovascular risk. Here, GFR is 45, 2 years later, GFR is now 30. They have progressed, and you need to consider also that the risk factor for cardiovascular disease has also changed. And while CKD is often at the risk of hypertension and diabetes, right, both impaired kidney function and risk factor. So if you don't have diabetes or you don't have hypertension, but you have impaired renal function and you have albuminuria, then you should consider that person as having increased risk factor. And this is based on this slide that has been over the years. And if you look at the patient, so the hazard ratio on the y-axis, and this is looking at the urine albumin creatinine ratio in milligrams per grams. And I must also take this opportunity to say that when you ask the patient to do this, because we find a lot of discrepancy, when they're doing the albumin creatinine ratio, please advise them to get the container from the night before, just as if they were going to do a 24-hour urine collection. Get the container from the night before, just a small container. And the first sample of urine that they've carried over in the bladder for the night, hopefully they're not a security guard on a night shift, or a nurse on a night shift, or anybody on a night shift. That first sample of urine goes in that bottle and they take it to the lab. Because if you're passing urine, like let's say midday urine to be used, it may falsely be negative, and then you're not capturing this level of albuminuria. But suffice to say though, that as your albumin level goes between 3 on that graph to 300, you can see that there's a 10-fold increase in cardiovascular risk. So the safest is around 75. And then when you look at, sorry, not 75, that's GFR. And when you look at the GFR, as your GFR falls, okay, your risk also increases. So you need to understand, this for this patient. And this slide has been around for many years. Now, macroalbuminuria is a mark of generalized endothelial dysfunction, as I mentioned earlier on. So this is just showing you the different condition and what is albuminuria or microalbuminuria doing as an endothelial marker or dysfunction. But if you focus on the one on the right, the graph on the right, and this is looking at the risk of incident proteinuria in the general population according to kidney and hyperfiltration. Why is it important that we mention hyperfiltration? Everybody knows when the GFR is low because the lab says GFR 59, right? And then you're like, oh, wait, something is going on. But what happens when the GFR is 150? Nobody knows about that because the lab, unfortunately, is just going to say it's greater than 60. But hyperfiltration in itself, as you can see, gives you an increased risk for developing proteinuria. So if you look at classically the diabetic and those persons who have sickle cell disease, if you look at their GFR, the creatinine, if you look at their creatinine for their weight and for their height or BMI, their creatinine is going to be very, very normal, almost supranormal. That should be like the first red flag. And all you have to do is just take out the calculator, punch it in, age, serum creatinine, and whether they are considered as black, punch in, you get a result, and you see that their GFR is actually very, very high. Okay, so it's like asking Usain Bolt to run a 100-meter race, no big deal, but ask him to run a 400-meter race with the same speed, and I can guarantee you he's probably not going to make it to the end of the race because it's not possible. So a kidney that is hyperfiltrating is a kidney that is going to be at risk later down the line. And the two main populations you should be wary of is your diabetic and those persons who have sickle cell disease. So this is what hyperfiltration does. So you have dilatation of the, well, this is in the diabetic patient. So you have that hyperfiltration, which will now affect all what is happening. Sorry, pointer doesn't work, but if you were, this is your glomerulus. So blood vessel goes in, you have dilatation, you have constriction, and basically what that does is just to increase your intraglomerular pressure. So if you increase your intraglomerular pressure, then that means the force at which things are being filtered is going to go up. And what's going to happen is once that goes up, you're going to have more protein being released. And if you have more protein being released, as the tubules reabsorb protein, it becomes toxic. So you're going to have tubular damage. Then you can end up with, problems down the line. And then for the same process happens in the hypertension, in the IgA nephropathy, and all the other things I would like to talk about in nephrology. And this is just, another definition in a way of what you should consider when somebody has kidney disease. And that's the category once again. So let's talk about the effect of lipids on the kidney. So the first thing we need to look at is the triglycerides, right? Everybody knows about triglycerides. See how elevated triglyceride, you should probably thinking, okay, maybe this is dietary related, maybe talk to them about their diet and dietitian. CKD in itself is associated with lipidemia, especially hypertriglyceridemia and low HDL. So basically I'm saying to you, CKD gives you high TGs and low HDL. And we all know that HDL has some kind of protective mechanism. So when you start to look at your HDL, non-HDL ratio to LDL ratio, then you're gonna start to see that is low. So the person has an increased risk for atherosclerosis, cardiovascular event. And this is generally what we see when you compare CKD with the general population. Chronic kidney disease also leads to a downregulation of lipoproteins, and we know lipoprotein lipase is responsible for metabolism of LDL receptors. That's going to engulf all that LDL, so that way you can lower your LDL. So if you have a disease process that is affecting your receptors, then you can understand why this will also cause an increased level. And APOA1, which we don't typically measure, but you might want to consider it in some cases. And then the expression is reduced in the hepatic cells, and that also gives you an increased risk. So what about lecithin cholesterol, which is something that we don't measure typically, and it's not recommended that you measure it, but this is another marker that we can use as to why triglycerides is high and HDL, and why these patients are predisposed to atherosclerosis. And then beyond the reduction in HDL cholesterol level, the HDL in CKD is also less effective as an antioxidative and anti-inflammatory function. So when you look at the HDL in the normal population compared to the CKD population, that HDL also seems to be less functional. So you have a whole host of processes that is affecting the lipid metabolism, lipid function in a CKD patient compared to the general population. So as CKD progresses, obviously the dyslipidemia worsens. So we need to be on the lookout for this person. They go from stage 1 to stage 2. We need to look beyond the lookout for them. And okay, so this is just talking about other things in terms of the actual number when you look at somebody from CKD2 or CKD1 and compared to CKD4. So we're talking about 45% all the way up to 67.8%, almost 70% increase when you look at the diagnosis of hyperlipidemia or dyslipidemia. And unfortunately, the use of lipid-lowering agent increases from 18 to 44.7 in CKD stage 4. Unfortunately, by the time it gets to stage 5, when they have end-stage renal disease, then we start to see all sort of different things happening depending on what you read and what you subscribe to. Okay, so when you look at this study, because it has a lot of people, greater than 21,000 persons with incident dialysis patient, they found a prevalence of 82% of dyslipidemia, right? And this is suggesting a threshold of non-HDL cholesterol of greater than 100. That's what they use as their cutoff. Okay, so 82% or 80% of persons with CKD on dialysis, which is ESRD, have dyslipidemia. So therefore, chances are, so if you have end-stage renal disease and it's due to either diabetes or hypertension, there's no real reason why you shouldn't be on a statin. Persons who are on peritoneal dialysis, is there any difference? I showed you that graph earlier on in terms of survival. There's a difference between end-stage renal disease on hemodialysis, they do worse. Then end-stage renal disease on peritoneal dialysis, they do better. And then the transplant do the best. But when you look at peritoneal dialysis patients, they have an associated higher cholesterol levels when you're compared to the hemodialysis patient. That's why you ask yourself the question, do they die more compared to hemodialysis patient? We said, no, their survival is better. But there are other things that predispose to higher risk, because in the hemodialysis patient, you're predisposed to more hemodynamic instability. That could be one of the drivers, and various shift in your potassium during hemodialysis session compared to peritoneal dialysis. So while the burden of CKD itself is the leading cause of, sounds very, same thing. Right. So risk factors for cardiovascular disease in persons with CKD include the traditional, which we all know: hypertension, your gender, your age, if you smoke, if you have a family history. And then CKD also appears to benefit from similar non-CKD patients from therapies that target these risk factors. So if they have all of the traditional risk factors, then we need to, address it. Regardless of the cause of the CKD, patients with CKD are increased risk of cardiovascular, which this slide is duplicated. But all right, so what do we do with lipid management? So the recommendation, so we have KDIGO, we have National Kidney Foundation, we have the American Association of the lipid panel from the Americans. So they're different body. But what you realize is this: most of them revert back to either the National Kidney Foundation, or more importantly and more frequently, they revert back to the KDIGO recommendation, which I will share with you. So everybody recommends the routine screening of adults and adolescents with CKD using the standard labs that we know, the fasting. All right, so we're going to check the LDL, we're going to check their HDL, we're going to check their triglycerides, and we're going to check their total cholesterol. Okay, so that is still recommended. We're going to do that for everybody. Although there's some studies that have found association with lipase A, remember I was saying to you, it's not something that is recommended as yet, but if you feel like you need to, then sure. Now, KDIGO's recommendation when it comes to assessment of lipid status, they give the same recommendation, okay? So that was National Kidney Foundation. KDIGO gives the same recommendation: check your total cholesterol, LDL cholesterol, HDL cholesterol, triglyceride, and you need to follow them up. Now, this is where changes might occur, okay? And the measurement of lipid is not required for majority of patients. So which means if you've checked their lipid status at the beginning and you've instituted treatment or therapy, you do not need to check them again. Now, I know if I were to do a vote, there's going to be different view of just the physicians themselves, but also when you have a patient in front of you in terms of how do you motivate them to be compliant with their medication. Okay? But before we pull the trigger, we need to rule out other remedial secondary causes of lipidemia. Okay? Establish the indication for treatment, whether you're going to go yes or no, discussion with the patient. And then you can go to the level of, if they say yes, what's the dose you're going to start off with? And that also depends on the concern that the patient raises. But be mindful how you start off with the dose so you can just titrate the patient. So that way they're less likely to have a side effect, and that will cause non-compliance. But also we need to consider treating according to fire and forget. This is the KDIGO recommendation. What does that mean? It means we treat based on the risk factor. If you were just at a cardiology presentation, then we talk about low risk, medium risk, intermediates, and all the different level of risk factors. You treat based on that risk factor, and they stay on the drug, and that's the end of it. Okay, but there's some practice that says, you know what, maybe you should give them a target. I still do targets sometimes, especially for the non-compliant patient. And you need to just to reassure the patient that, listen, if you don't take the medication, we can see what is happening with your levels. But if you have a patient that is very compliant and causes an issue in terms of doing tests and those things, that might probably be a selling point, too. I tell them, one of the things I say to my patient, because when you send them to do cholesterol level, the worst that can happen is when the cholesterol comes back at 5.1. The total cholesterol, the arrow says is less than 5.3, and they're looking very happy, like, so I don't need to go on a statin. But that is just a misnomer. This cholesterol is for somebody who does not have diabetes, doesn't have high blood pressure, doesn't have CKD, doesn't have any of the risk factors. This is what their cholesterol should be. So sometimes showing them a figure or the recommendation of where the cholesterol level should be might be important. Or do people use the atherosclerosis risk calculator? If you use the risk calculator and your risk is greater than 10%, then you also will say to them, listen, you have a risk in excess of 10%. Recommendation says I should put you on a statin. But you have to show them something so that they can understand why you are prescribing the drug. So I just put this there because a lipid profile every year or two in CKD patient under the age of 50 who is not currently on therapy will help to risk stratify this patient when statin therapy should be initiated. Okay? And the physician can choose or may choose to perform follow-up measurement in lipids in patients for whom these measurements are judged to favorably influence adherence to treatment. So you may not want to use that fire and fire and trigger approach. You might want to use this. So what drugs should we be using in these patients? So the recommendation states, this is the American College of Cardiologists and the American Heart Association guideline in 2018. So if you have an adult, okay, more than 50, I guess if they're 49, you just bring them back when they're over 50, and so you can talk to them. If you're not treated on dialysis, on renal replacement therapy, I should say, meaning no dialysis, no kidney transplant, you recommend that they need to be on a statin or ezetimibe combination. And as you can see, that is grade 1A recommendation. So which means there's benefits in starting this patient, and there are randomized trial that has been documented that supports that also. If you have an adult that is more than 50 years of age with CKD and their GFR between G1 to G2, you guys remember what G1, G2? So that's those persons with GFR is greater than 60. They recommend use of a statin. If you have an adult, they're now less than 50, but they're greater than 18, meaning they're 18 years old, and they're not on renal replacement therapy again, we suggest treatment we suggest treatment in patients with one or more of the following, meaning they're younger than 50, they're not on dialysis, but you need to look for an additional risk factor so you can start them on a statin. But look at the level of evidence in terms of recommendation. It's a 2A recommendation. So if they happen to have coronary artery disease, they have 40-year-old who's had stent in place, because they have a familiar risk factors. If they have diabetes, if they have prior ischemic stroke, or if you do the calculation using that good old Framingham risk calculator score, and they have greater than 10% risk, then you should put them on a statin. We can debate whether we will follow that recommendation as it is or what's the interpretation of it, but I will, welcome your comment on that. Now, what about adults who are dialysis dependent? That's where it gets a little bit tricky. So adults dialysis dependent, they suggest statin or statin-ezetimibe combination not to be initiated. So does that mean if the patient was started at CKD stage 4, do we stop it? No, we don't stop it because it already has that risk. So here it says not to be initiated. And I can't imagine any such patient who has undergone CKD from 1 to 4 that doesn't meet the criteria to initiate statin, and then all of a sudden now at A-stage renal disease, they need to. So that is open for discussion. As you can see, the level of recommendation. So if you also have a patient who's already receiving statin at the time of dialysis initiation, we suggest that the agents be continued. That just sounds like what I was saying earlier on, right? So when you look at the guidelines and recommendations, there's some area that's just not so cohesive and not so gel. But as you can see, you're gonna find very little patient not gonna need a statin. And then adults who have kidney transplant recipient definitely must receive a statin treatment. So we're basically talking about those persons on what? On hemodialysis and peritoneal dialysis, who are not diabetic, who don't have any other risk factors. And then all of this is now suggesting which drug we should use. So if we look at some of the trials that led to some of this recommendation, based on the ALERT trial, which is the assessment of, let's call it, renal transplant trial, more than 2,000 patients, and they were randomized, and they realized that, giving fluvastatin was not only just effective, but you could also increase the dose from 40 to 80 milligrams. We will have done the first 2 years to make sure that, this was a safe drug, and they realized that it was safe, and they increased to 80 milligrams. But it also shows a reduction in cardiac death by 38% in that population. So it did two things. One, it says, moving from 40 milligrams to 80 milligrams was quite safe in these patients, right? And also that we're able to reduce their cardiac death by 38%. What about specifically lowering triglycerides? So if you have adults with CKD who are not on dialysis or kidney transplant, we suggest using what? Lifestyle changes to be advised initially. So technically, it sounds like your CKD patient should be seeing a dietitian also, and then for other reasons also, all right? In the SHARP, a lot of people will be familiar with the SHARP trial, right? And this is a study of heart and renal protection. And in this trial, what they looked at, they randomized close to 10,000 people, more than 40 years of age, with CKD to receive simvastatin plus ezetimibe, 10 milligrams daily, regardless of what their LDL level was, right? And patients that were eligible, then they checked their creatinine. And what did they find? Combined myocardial infarction, coronary death was reduced, stroke, or the need for revascularization was reduced by 17% in the treatment group, with a mean reduction of the LDL by 32%. And if you look at some of the guidelines, especially from KDIGO, it says even if you don't aim for a target LDL reduction, just start them on a statin to give them any kind of reduction in the LDL level is still considered to be beneficial. All right, so we have persons with LDL, regardless of the LDL, you reduce it by 32%, and they still had some benefit in terms of cardiovascular exposure. And if they were to complain, about myopathy, this was one of the main problems, but the incident was reduced in those persons who had myopathy. Okay, I think I just heard myself a while ago. Now, KDIGO recommendation of use of statin in CKD. Persons with CKD are at higher risk, as we've already said many times. So given reduced renal excretion, should we need to consider that? Polypharmacy, we need to consider that, and multiple comorbid condition. These are things that we should consider before initiating statin. So what did KDIGO recommend in terms of statin that can be used? And as you can see the list there, fluvastatin and pitavastatin, I'm not sure. I think fluvastatin might be available in Jamaica, but certainly pitavastatin is not available. But these are all the things that are recommended. And for those persons, if you're doing moderate intensity of statin therapy. What about liver? Yeah? Because patients will come to you, they talk about the muscles, and then they talk about the liver damage. Okay, baseline transaminase should be measured in all CKD patients prior to starting, just because you want to know whether they have the existing problem. Routine transaminase for CK levels is not recommended in the absence of clinical evidence of hepatotoxicity or myopathy, although sometimes the patient might actually request it because, you know, next door neighbor had liver disease and they were taking simvastatin. So I will oblige them at that point in time. Okay. If they complain of myopathy, the easiest thing to do, rather than stopping it, just go one dose less. And then you tell them with positive reinforcement that I bet you when I reduce the dose, it's gonna go away. You give them the placebo treatment. And when they come back, the symptoms are less. At that time, you might decide whether you want to reevaluate the LDL level. Okay? Okay, I didn't do that. Fibrates should be avoided in combination with statin in patients with CKD. Okay, so we don't usually recommend using fibrates. Ezetimibe monotherapy alone, well, obviously that's why I say monotherapy, it's not recommended. So who gets ezetimibe in those who complain of myopathy, and when you really try to reduce the dose, you find that you're moving from 20 to all like 5 milligrams. There's some patients that I have on 5 milligrams Monday, Wednesday, Friday, you know, because they do have that myopathy or they have that pain. I might now add ezetimibe just so I can get to my target. Okay. Single drug toxicity is less of a concern with better renal excretion. All right. Especially for those with stage 1 and 2. And I tell my patient, if I diagnose you with stage 1 or stage 2, it's almost inconsequential to you, right? I'm making a diagnosis of CKD. Yes, I need to reduce the progression. I need to treat the underlying cause, but it's almost as if it's, you know, I don't need to adjust anything as yet at that stage, okay? So they can be treated with the same dose like the general population. Now we can crush it up. So in summary, I just put this there, you know, for those persons who would like to take pictures. You can take a picture of it because it just gives you recommendation based on everybody. So you can decide which one you're going to follow. And even more importantly, to understand the rationale why the National Lipid Association recommendation is going to be different from the American College of Cardiology recommendation, and it's going to be different from the KDIGO recommendation. But I'm a nephrologist, so we'll go with KDIGO guidelines, which, as I mentioned earlier on, the American Association of Cardiologists also will recommend that on there. So when you go to their website, they will revert you back to what KDIGO recommendation is. So in summary, if you look at a patient with chronic kidney disease, they have all of this problem. Some of them are traditional risk factors. Some of them are non-traditional risk factors. That is going to cause them to have cardiovascular event. And if you, by any chance, can address all of this, then you have a patient that is more likely going to have a better outcome in life. Okay, so screen for all of this and prioritize how you're going to treat each and every one of them. Thank you.
Thank you so much, Dr. Soyibo. And of course, that picture that he had shown at the front, I kind of took offense to it because I kind of showed me when I was back in my prime and all what age has done. So thanks again, Dr. Soyibo. We are now ready for questions, and of course, he'll provide the answers. So we'll take questions from the floor and of course online. So we'll start with the online people.
All right, thank you so much. Congratulations, Dr. Soyibo, on a wonderful presentation. I just want to thank Dr. Arna Brown Morgan from the Agpj who has entered. First question here from Dr. Palmer. Actually, that one's for Dr. Harvey, so let's go to this one. From Dr. Green. For a patient with risk factors for CKD, whether hypertension or diabetes, with an EGFR greater than 60 or stage 1 to 2 CKD, should these patients be referred to nephrology or to optimize risk factors?
That's a very good question, because if you look at the ACP, American College of Physicians recommendation, it says when you get to stage 3, then you should refer to nephrology. But if you look at KDIGO and you look at the ASN, American Society of Nephrology, they do not agree with that. So what's my take on it? If you have it depends on your level of confidence. And my other colleagues, nephrologists, might differ. If you're confident about the diagnosis of this CKD, then maybe you don't need to. But the problem arises, which we tend to see, especially when you do rounds and you have the benefit of all the file on the ward, is that a patient who's diagnosed with CKD stage 1 or stage 2 and has a calcium that is elevated, that should raise a red flag that this is probably not just CKD 1 and 2, because at that stage, you don't expect any level of disproportionate in calcium homeostasis. And then I give you another scenario. The patient now presents later on in life and they have CKD stage 4 and 5, and then their calcium now is normal, in the normal range. That again is not what I expect, because if you have somebody who's untreated CKD for so many years, they should have hypocalcemia. So there's a driver that is pushing the calcium in one direction. So you need to find it. Unfortunately, if I'm finding that driver 4 years later, then you can imagine if I make a diagnosis of multiple myeloma or some kind of malignancy, I would have missed the boat, something I could have treated 4 years ago. So if you feel like you're comfortable with the diagnosis of the CKD, then fine. You don't necessarily need to refer. But some people might say, you know what, just err on the side of caution. These are my diagnosis. This is a one-time to see, and tell me what your opinion is. Was that the only question? Yes.
No, sir. We have a few more. Thank you. And on the screens for persons in the room, if you've not yet registered, and I don't mean sign the form outside because I know you did, but to ensure you get your CMEs, because it's a digital certificate, please just type that link in that you're looking on, or scan that QR code if you're savvy enough, and put your name and your email address into the form. So the study presented spoke about fluvastatin. Is this drug superior to rosuvastatin, atorvastatin, or simvastatin?
Oh, well, yeah. So now we're talking about statins and their equivalent. So unfortunately, population, you're not going to have any head-to-head comparison to state that. But drawing off from previous studies, and they looked at, statins, so tends to be more rosuvastatin, atorvastatin, as being the superior, and everybody else sort of, falls after that. That is, what I know. I don't know if anybody else has any other recent data to suggest that. But the reason why I probably wouldn't use a high dose of simvastatin is because of the risk associated with use of higher dose, more than 40 milligrams. Whereas I'm not going to get that problem if I'm using rosuvastatin or if I'm using atorvastatin.
Thank you so much. Is renal productive medication, ACEs, still indicated for newly diagnosed diabetics?
Absolutely, if they have proteinuria, definitely.
All right, we have a question in the room.
Good morning. I'm Dr. Simmons Brooks from Sickle Cell Unit. My question relates to the use of statins. Well, I see your presentation was about dyslipidemia, but we have categories of patients that are high risk at the unit. And you have some patients that don't tolerate hydroxyurea well, or even ACE because of their blood pressure. My question is that, is there a role for statins in patients that we identify as microalbuminuria to prevent progression to kidney disease?
That's a very, very big question that, I will throw it out to you so that you guys can do the study. I'm not aware of any trials that looks at specifically sickle cell population, right? That's the question you're asking.
So I've seen a study, I think it was back in 2013, researcher Hope et al. Looking at 19 sickle cell patients, and they did notice reduction in pain and vaso-occlusive crisis. And I've also seen a study in mice models where they said that it reduced the severity and survival of pneumococcal infections with the use of statins. But I just wanted to know if there is any use, if you have patients that, in your clinical practice, if it is that you found any use for it. Especially in those who don't tolerate hydroxyurea or ACE inhibitors or ARBs.
So if so even anecdotally also, there's a trial that looked at statin and the reduced risk of infection. But what we're talking about is cardiovascular risk, right? So in terms of statin and reduction in cardiovascular risk at the end for sicklers, no, I haven't seen any. But having said that, I don't think that the recommendation to use statin in sickle cell disease is to reduce their veno-occlusive crisis or to prevent renal progression of their renal disease or reduction in their GFR. Those measures are the ones that you mentioned earlier. So the use of hydroxyurea, ACE, ARB, in combination, if they have high blood pressure, treat their blood pressure. But specifically for statin to reduce those, I'm not familiar with any. Now, if you have somebody with sickle cell disease, because remember now, sickle cell disease patient also may develop other diseases. They have diabetes, if they develop high blood pressure, if they have significant proteinuria, or you do their Framingham risk score calculation and it's greater than 10%, then sure, you should consider putting them on a statin, but not to substitute for hydroxyurea.
Thank you very much. What happens when a person is borderline hypertensive? Should medication be a priority, or should the individual get counseling with dietary changes? I noticed both wasn't an option.
So you have somebody who is borderline hypertensive?
Yeah, and I'm not sure what that's defined as.
Well, I guess it depends on which guideline you're looking at in terms of the recommendation or the diagnosis of what is hypertension, what is not hypertension. But suffice to say, though, it sounds like the person is sitting on the fence. You're not quite sure whether they are hypertensive. It's better to look at all the other risk factors. Okay? So the person is not quite hypertensive. The person is not quite diabetic. The person is not quite obese. The person doesn't have that significantly elevated uric acid level. The person has a family history. You understand the picture I'm trying to paint? They don't fit anything as yet. but they have all these little risk factors. That is somebody who you should definitely encourage TLC first, because their therapeutic lifestyle or total lifestyle changes will be of benefit to all of those parameters. And then if they still don't reach their target, then you could consider individual treatment. Or if the person who is borderline hypertensive has proteinuria, then sure, I will use ACE or ARB for that person.
Thank you so much. How effective is kidney transplant? And how long does it take for one to recover after having a kidney transplant?
How effective? Well, if you look at renal replacement therapy, the recommendation for anybody with CKD is you need to explore transplant, kidney transplant. So, but unfortunately, not everybody who has CKD is going to get a kidney transplant, either because of atherosclerosis, either because of increased cardiovascular risk, so they may not be able to get a kidney transplant, or sometimes because of fear of recurrence of the disease. So if you have a disease that destroyed this particular kidney, if I give you a new kidney, there's an increased risk of having recurrence, then I'll be a bit guarded in doing kidney transplant. So kidney transplant is #1 recommendation treatment for anybody with end-stage renal disease. So I'm going to assume if that's #1 recommendation, then it should be the best. And then you can debate whether you want to do hemo or PD, because both have their positives and they also have their negatives. But kidney transplant is #1 recommendation.
Thank you so much. For patients with hypertension and type 2 diabetes with a normal cholesterol level, is it imperative for them to be placed on statins?
Yeah, so that sounds like a yes answer. Because remember, regardless of what the LDL cholesterol is, if you calculate the atherosclerosis risk factor based on those two things that you've said, it's going to be more than 10%.
Thank you so much. Is a lower than normal blood pressure without side effects better to prevent CKD in the future?
Sorry, lower than normal blood pressure?
Lower than normal BP without side effects better to prevent CKD in the future. I'm assuming doctor is asking if you've gotten the blood pressure down, if this person is hypertensive, right? Without side effects, right?
Right, you know, that's, I mean, the answer will be, if you were to think about it mechanistically, it would be, the answer would be yes. But you have to be careful that they're not suffering other organ hypoperfusion because of that low blood pressure. Okay, so, but I would say yes, you know, the lower you can, and this is from, you know, SPRINT trial and some other trials that looked at, you know, very low blood pressure, or what's the target in anybody. But also be careful in elderly people, you know, not lowering their blood pressure too much, because obviously, you know, their reflexes are going to be dampened because of age and atherosclerosis, so they may suffer consequences of hypoperfusion.
Thank you so much. Ladies and gentlemen, please give a round of applause to Dr. Soyibo. Thank you so much. Before we go back to Nakia, we have a question here for Dr. Harvey. Doc, I think they were waiting until they had a snack. Doc's like, no, we don't. No, we do not. Doc, the question is, you mentioned, Dr. Harvey mentioned that he doesn't recommend boric acid inserts. What is to be used for fluconazole-resistant candidiasis? Did I butcher that? Thank you so much. I take my degree in the mail, MBBS.
Itraconazole.
Hydrocolazone. Quickest answer. Itracolazone. Itracolazone. Thank you so much. All right. So now we head back over to you, Nakia.
Thank you. So Dr. Harvey, even though you're a little bit towards the side of the room, they still want to capture you, you know, we don't want to lose you. So Be comfortable. There will be more questions. Okay, so excellent presentation, Dr. Soyibo. And of course, I can see by the amount of questions that were fielded that person are actually really engaged, and we like that. So we do have a very robust online presence. We have approximately 1,000 persons on the Zoom platform, and now we are running into the YouTube link. So I just want you all to stay put as we continue this excellent summit. So we're just gonna move into our next presenter, who is actually online. So we're kind of shifting things a bit. So now you become the virtual persons to that person. So we'll ask our next person, Sandoz colleague, Ms. Sana Pitkinkova, to introduce that speaker. Please welcome her.
Thank you, Nakia. Good morning, everyone. To those in person and online, it is a pleasure to have you here with us today. My name is Sana Pitkin-Cover, as Nakia said, and I have the pleasure of introducing to you our distinguished speaker, Dr. Dwayne E. Hall, MBBS, DM, FACS, FCCS, FMAS. Dr. Hall graduated the University of the West Indies Medical School in 2000 with his MBBS. He would later return to his alma mater to complete his doctorate in medicine and general surgery in 2009. Dr. Hall acquired fellowships with the American College of Surgeons in 2015, and most recently, the Caribbean College of Surgeons in 2021. He serves as a consultant surgeon, heads the Department of General Surgery, and has been the chief of the surgery department at the Corner Regional Hospital since 2016. Trauma medicine, vascular medicine, and oncology are some of Dr. Hall's special medical interests. However, our humble surgeon is definitely balanced in life and in his interests as well. His favorite pastime is football. And despite having an extremely hectic schedule, serving in the public domain and having a thriving private practice, Dr. Hall manages to find time to go to the gym. Health is wealth, and Dr. Hall certainly subscribes to his mantra. Dr. Hall has two beautiful children, DeAndre and Imani, and is every bit the doting and super supportive dad as he is a superstar surgeon. When asked about his favorite food, he mentioned having many, but placed seafood at the top. We will have to ask him if that is SEA or SEE food. Ladies and gentlemen, please join me in welcoming my surgeon, who serves with a smiling heart, Dr. Dwayne E. Hall, as he presents on pathophysiology and management of venous disease. Thank you.
Good morning, everybody. Just trying to get this presentation up. And so this morning, I'd like to thank Sandoz for the opportunity to present on the pathophysiology and the management of venous disease, which is a very common problem that we have in Jamaica. The disclosure and the disclaimer. Now, chronic venous disorder or insufficiency, both terms sometimes are used interchangeably. It's a very common medical problem, as mentioned earlier. And a lot of times our patients actually ignore these problems because they think it's not too detrimental to their health. And that's one of the problems that we have in Jamaica with chronic venous disease, where patients actually present late. As with most other conditions that we see in medicine, a lot of these patients will come to medical attention at a stage where they're at the last end of the spectrum in terms of what could have been prevented. So if you look at American statistics, it affects more than 25 million Americans, America having a population of about 300 million. And the estimated prevalence is about 25 to 30% of the adult population. All statistics suggest that males and females are affected unequally, where females have about a 3-to-1 ratio as compared to males. But recent research is actually showing that males are almost as equally affected as females. I think one of the issues behind that is that females tend to attend medical practices far more readily than a male, and as well as chronic venous disorder normally affect legs. And legs is a big thing to a woman as compared to a man, as most men will wear long pants during the day, which will hide all of the problems that are associated with venous disease, where women have to dress usually in clothes that will expose their legs. It's often overlooked because it's really underappreciated, especially by medical practitioners. And one of the issues is that when it starts, it usually starts with swelling. And because the swelling usually disappears with a good night's rest, most patients will take it as nothing until they start get other changes that will bring them to doctor for an explanation of the problem. Now, one of the biggest things that affect the patients is actually how it affects their social and occupational activities and the reduction in the quality of life that they have. I mean, for a lot of patients with venous disease, especially when they get to the stage of ulceration, they pretty much have to leave general society because of shame. Sometimes because of these weeping wounds, they can't get dressings very often. So for some patients, they start to have an odor, which is associated with the wound. And because of this, they stay away from society, and it leads to depression and a significant reduction in the quality of life that we can't ignore. One of the things with a lot of these patients is that they're poor, and because they're poor, they have to take public transport. And of course, if you have to go to a clinic to get dressings 3 times per week, a lot of times it becomes difficult, because if your wound is bad, you can't really take public transport anymore. You have to charter a taxi, which comes at a significant cost. Right? And as well, when the wounds are bad, these patients cannot work. If you cannot work, you're not going to earn. And a lot of these patients are even self-employed. So it's not that they can take sick leave and earn while they're at home. And in America, it affects about 2 million work days per year, which is very significant. It's about 12% of workers that actually have the disease. And of course, with dressings, we often ignore the cost in Jamaica because healthcare is free. But in countries that you pretty much have to pay for medical care, or the country has to spend money on each person with this problem, you'll realize that it costs a lot. And in Western countries, the cost for treating venous ulcers will approximate about $3 billion. And this is US dollars. Now, who is at risk for this problem? Older patients, patients with a family history of the disease, patients who do prolonged standing. And this is what most of our patients fall under this group, which is prolonged standing. So patients who are teachers, policemen, soldiers, especially with these states of emergencies, doctors, especially surgeons, because we stand for long hours doing operations, sometimes for days at a time. I remember doing residency at KPH, sometimes we used to operate 2 days straight. So we are at a significant risk. And I'll tell anybody here who is listening, if you do a profession or a job that you have to stand a lot, you should get some stockings and start wearing them from now as prophylaxis against this problem. Obesity, because these patients are often sedentary, they often don't move around a lot. When you don't move around a lot as well, your calf muscle gets weak, you get calf muscle dysfunction, and this puts you at risk for the problem. Smokers, sedentary lifestyle, as mentioned before, lower extremity trauma, which is becoming more and more common in Jamaica with the advent of young bikes. I mean, in Western Jamaica, we have bike accidents every day. We get lower limb fractures every day. It's even worse in Westmoreland as compared to Montego Bay. And the number of patients affected by lower limb fracture is actually significantly increasing because a lot of our young men have turned to lifestyles where they ride bikes and they ride carelessly on the road. And they not only get a lot of head injuries, but they get a lot of lower limb trauma, which lead to fractures, which destroy the veins, and they end up with secondary venous disease. Patients who have had prior DVTs, because DVT actually damages the deep system, and I'll explain later as we go along how this will affect the prognosis of the patient or the sequelae when you have it. The presence of arteriovenous shunts is usually a congenital problem, and women who have high estrogen states and multiple pregnancies. And as you know, the more pregnancies you have, usually if you have varicose veins from the first pregnancy, the more pregnancies you have, the varicose veins actually worsen. Similarly with hemorrhoidal disease, they worsen as well with recurrent pregnancies. Now, in order to understand what happens, with surgery is pretty much anatomy and physiology combined, and how it affects the patient and how we address both. So within the legs, there are 4 systems of veins. There's a deep system, and these are the veins that run close to the bone within the muscle. And the names, as you see on the slide, common femoral vein, profunda femoris, superficial femoral, popliteal veins, and the tibial veins. Then you have the superficial system, which is made up of the great saphenous vein and the short saphenous vein and a few veins that interconnect them. Then we have perforators, and the perforators pretty much are a group of veins that join your superficial to your deep system. So they form like a H pattern, where the superficial system is closer to the skin, the deeper system is closer to the bone within the muscle, and the perforator joins both where it crosses a fascial layer. And then we have communicating veins, which pretty much connect the superficial to the superficial system and the deep system to the deep system. And it's important to know these systems because the more systems are affected by this disease, is the worse that the clinical presentation of the patient would be. And now normally how blood flows within the lower limb, it flows usually from your superficial system through your perforators into your deep system. And when you move around with contraction of the gastrocnemius and the soleus, the blood is pumped back up to the heart with the aid of the negative pressure that's within the abdomen and the chest. And that's how blood normally flows. So it's pumped actively into the leg from the heart and returned through our calf muscle pump and the negative intrathoracic pressure. This is just a little schematic diagram to show you what the veins pretty much look like. Now, with venous disease, it can either be as a result of valvular dysfunction, and valves are present within most veins of the body. And what valves do is to ensure unidirectional flow of blood. So because blood flow within veins is not actively pumped from the heart, blood flow in veins goes up and down, so it moves like this. So with the downward movement of the blood, it's blocked off by the valves, and there's continuous pumping to push this column of blood all the way back up to the heart. So if the valves are not functioning properly, the blood is going to head back down, all the way back down to where it's coming from and form like a column. And as you remember, probably persons who did physics, you have a column of blood, it's like a manometer. The taller the column of the blood is, the higher the pressure at the bottom. And this is what happens in the legs, especially when you're standing. So if you stand, if you look on the great saphenous vein, which runs from the groin all the way down to the ankle, at the level of the ankle will be the highest pressure if there's valvular insufficiency within the system. Venous obstruction from DVT, because DVT actually blocks off the vein. It usually occurs around valves as well. And when these veins are blocked, the only way that blood can leave your leg is now to find a new path. And this new path is usually as a result of destruction of the valves within the perforator, so the blood can get back to the superficial system and back up to the heart. So whenever you have a DVT, you will get secondary dilatation and destruction of the perforators and the superficial valve. But this is as a result to restore normal blood flow in your leg. And this is very important because if there's DVT and the patient needs some form of treatment, you cannot trouble the superficial system, because if you remove the superficial system or close it off, then the pressure within the leg is going to get high and this patient will be at risk to lose the leg. And then there's muscle pump dysfunction, where the calf muscles are not strong enough to get the blood out of the leg. And of course, a combination of all three. So if you have a combination of all three, then the clinical features are going to be more significant. So this is just a overview to just remind you of what I said earlier. If you have destruction of the valves as well, venous disease actually goes and moves very faster. And these patients, especially if the deep valves are affected, because within the deep veins is the highest pressure. So if these valves are affected, the pressure that's there within the deep system is going to be transmitted to the superficial system. And the superficial system is actually not designed to actually manage this high pressure. And it's a high pressure that comes out into the superficial system that leads to the dilatation and the tortuosity of these veins, which pretty much when they show up, which is what we call varicose veins, or reticular veins, which pretty much are the same thing, just that varicose veins are of a larger size as compared to reticular veins.
Hi, everyone. Thank you. Yes, apologies. As you can see, we had an internet issue there with Dr. Hall. We have him on the line. We're trying to get him to rejoin. It's a wonderful time to say thank you to Sandoz and Agpj for putting together this health summit. And we didn't cheat. We kept it as realistic as possible. All right, so he's going to try to log on again. Please remember, if you have any questions for Doc so far in this wonderful presentation, please put them in the Q&A. And of course, persons in the room who have been attentive so far, you can write them down and use the microphone in the center of the room to ask them when that time comes. So we're just waiting a little bit. In the meantime,
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundl. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zinat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotic site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We're proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why...
All right, yeah, sorry, Dr. Hall, can you hear me?
I can hear you. Can you hear me?
Yes, we can. And that intermission sponsored by Jamaica Public Service Company, JPSCO. How comes? Welcome back, Doc. We're with you. It's been an awesome presentation so far, so please take it over and continue.
All right, sorry about that, guys. I mean, Venous, what I was saying earlier, is that in the normal person, when we stand up, the pressure within our veins can go as high as 80 to 90 millimeters of mercury. And what happens when we walk around in the normal person is that the pressure is supposed to get less. And this is something that we must always try and remember. So movement is actually good. Movement actually removes the blood from the veins. And in fact, when you're not moving, usually the blood that's within the veins below your knees actually stagnant. Right? So movement actually pumps blood out of your foot and actually reduces the pressure. And if the pressure is reduced, you actually protect the veins from damage and actually protect yourself from getting venous insufficiency. And this stagnation of blood actually is very important to us as surgeons because we actually take precautions during operations to prevent patients from getting blood clots. Now, in a patient with chronic venous insufficiency, this decrease in pressure does not occur, either because of the insufficient valves or because of an obstruction. So when they walk and the calf muscle pumps, the pressure actually is increased. And this phenomenon is called ambulatory venous hypertension. And ambulatory venous hypertension actually is the hallmark of the problem that leads to chronic venous insufficiency. And every single method that we find in order to help these patients must reduce ambulatory venous hypertension. Now, the image on the left is pretty much how blood typically flows. Up and down, as I tell you before, they go right through the valves, and if during the downflow, the valve closes off to prevent blood from heading back down, and then it continues to go all the way up with the pumping of the calf muscle. And the picture beside it is actually when you get a clot, which we call deep venous thrombosis, and this actually occludes the system. What is important about DVTs is that DVTs need to be treated aggressively. We need to treat it aggressively so that the clot that's within the vein can actually recanalize. And with recanalization, blood will actually start to flow through the vein again. And this will actually reduce venous hypertension. But the next reason why we need to treat it aggressively is because 20 to 30% of these patients who get DVTs actually end up with chronic venous insufficiency, what we call post-thrombotic syndrome, or the post-thrombotic leg. Now, with ambulatory venous hypertension, what happens is that this pressure is actually pushed all the way back to the capillary level. So if you remember physiology, the arterial and the venous system is actually interconnected through capillaries, arterioles, and venules. So that when the pressure is high at the level of the capillaries, what actually happens is that the hemoglobin from red blood cells goes out into the tissues, and the hemoglobin is actually broken down. And once broken down, it changes to hemosiderin, which is a black pigment. And this black pigment starts to tattoo the leg. And it normally tattoos the leg at the area where there is highest pressure. And this is actually at the level of the medial malleolus, which we typically call the gator area. So usually once the skin starts to become black, those patients who have ignored the swelling that occurs on a day-to-day basis will now start to take notice. And then some of them will actually come to hospital now because they start getting scared. Because Jamaican people, once they see anything going black, they start associated with it. So this will scare most people and they'll end up in the doctor's office to get this checked out. Some of them will ignore it and continue on their daily lives. White blood cells, when they come out of the system, they become activated within the subcutaneous tissue. And white cells, as we know, are natural killers. But here, they will start to kill your own tissues with the substances that they produce. And the plasma proteins that come out, the theory behind the plasma protein, which has not been proven, is that they create a barrier, which is called a pericapillary cuff. And this barrier pretty much shields your capillaries from the tissues. And what the tissues will do as a result of this is being starved of oxygen and the nutrients that keep them alive. And you find that with a combination of lytic substances from white blood cells, as well as tissues being devoid of nutrients and oxygen, tissues start to break down. And this is the onset of the ulceration. So sometimes when this has started, now the patients will end up in hospital as well, or end up in the doctor's office because they start feeling a biting sensation within their feet at the level of the gator area. Now, the issue with this is that still a lot of patients will ignore this, and a lot of times because of the activities that they do on a daily basis, they will tell you that something hit them on their foot and it forms a sore, and they realize that the sore is just getting bigger and bigger, not thinking that this sore is actually caused by what's happening from before with the swelling, with the hyperpigmentation, with the biting pain, and now the tissue is actually being eaten away daily. With the ambulatory venous hypertension being maintained, the natural history of that ulcer is that it's going to get bigger and bigger and bigger with time. Now, once you have ambulatory venous hypertension, in fact, it affects the veins and it affects the subcutaneous tissues. And these are some of the things that the patients will present with. So they start to get telangiectasias and spider veins, which move to reticular veins, then varicose veins. Then they start to get the swelling, which is edema. Leave this long enough, they end up with pigmentation, they get dermatitis. So sometimes they actually end up at the dermatologist's office because of the inflammation of the skin. And dermatologists actually play a very important role in treating patients with chronic venous disease as well. And they will manage some of them, and then they will transfer some to the surgeons who they believe need intervention. Left for longer periods of time, then you get scarring and fibrosis of the tissue, which we know as lipodermatosclerosis. And when you touch the patients in the area that's affected, the skin will start to feel leathery and hard. And then when they have had ulcers and the ulcers heal and recurrent breakdown and healing, the tissues in that area actually appear white. And this is what we call a trophy blanche. And left alone, the last thing is the venous ulcer. So we actually want to pick up the patients at an earlier stage before they get to an ulcer to prevent them from even getting ulcerations through education and through treatment modalities. Now, when it comes down to the physical examination should be done with the patient standing, because if the patient is lying down with the leg at the level of the heart, the pressure within the veins are zero. So there will be no distension. So you ask the patients to stand. And when they stand, you'll start to see filling of the veins and the varicose veins and the varicosities. They will become more evident. In the picture on the left, which is a picture of one of my patients, this patient actually wasn't standing up, but I took it quickly as the patient lay down, so you could actually see the varicosities in the medial aspect of the right leg, so that those tortuous veins that actually look like snakes under the skin. And this is actually a male patient who is a farmer and has had this problem for over 20 years. Now, when the patient stands, what you need to do is take note of where the veins are, the dilated veins are, meaning that if they affect the medial aspect, the lateral aspect of the leg, and you must also look on the thighs. And importantly, in women who have had some form of chronic pelvic pain, you must also check the vulva to see if there are dilated veins on the vulva, which can be associated with pelvic venous disorder. So sometimes the manifestations that we see in the leg, especially in women, are not related to a problem in the leg, but a problem in the pelvis. And when you check for edema, you'll also notice that most times the foot of the patient is actually spared. A lot of times when there's edema, the foot is another problem apart from chronic venous insufficiency. Now, when you see a patient with an acutely swollen limb, right, the differentials include an acute DVT, which normally comes with pain and swelling. And sometimes with the DVT, the patient may have a long history of a sedentary lifestyle or recent long travel, like probably flying from Jamaica to the UK, or even driving on a bus from Montego Bay to Kingston, right? An acutely swollen limb must never be ignored, because acute DVT can lead to a pulmonary embolus that may be fatal. So these patients always need to be investigated. And your clinical history actually will give you the rest of the information to see patients who have congestive cardiac failure, kidney and liver disease, endocrine disorders, patients that are placed recently on the following drugs, patients with lymphedema, and lymphedema actually can be secondary to long-standing chronic venous insufficiency. So a patient may actually present with lymphedema, but the problem actually starts from chronic venous insufficiency, which you can get from the history when you talk to these patients. And then there's the patients who usually are managed by orthopedic surgeons who have a ruptured Baker's cyst, which occurs in the popliteal fossa and causes acute swelling of the calf muscle. Then there's patients who complain of pain with activity, usually younger patients, which we call exertional compartment syndrome, which is due to swelling of the lower limb muscles with activity, and then patients who get muscle tears. So what are some of the clinical features that these patients may complain of from the history? With the swelling, they complain of heaviness of the legs, right? And depending on the degree of heaviness, right, some patients actually will just ignore this. As I said before, because the heaviness disappears with you sleeping in the night. They complain of tired legs or fatigued legs, which usually bothers them in the evenings when they get home, right? And of course, with almost all symptoms in medicine, patients feel more things during the night, because during the night, there's no distraction. The TV's off, there's nobody speaking to you. Some patients may be on the phone, so pretty much they start to hone in on what their body is telling them, and they'll feel these tired, fatigued legs. There's a feeling of swelling, again, similar to heaviness. There's itching, so there's a dermatitis that can be associated with venous insufficiency, and it causes itching. And they normally feel the itchings usually in the evenings and in the night, because one of the hallmark features of chronic venous insufficiency is that the symptoms get worse during the day. And this is something that you must always pick up from your history. Patients are fine when they wake up in the morning, but as the day goes on, almost all the symptoms get worse. So the swelling comes first, then the pain will come, then the biting feeling will come, and then when they get home and they start to lie down or the distraction disappears, they start to feeling the nocturnal cramps and the tired legs. Some people, because the swelling is so bad, they can feel throbbing pain in the legs. And then once ulcerations become, when the ulcers are right around the corner, then the aching and the burning pain gets more, right? Venous claudication actually is not so common, but when it occurs, sometimes these patients are referred to the hospital as actually peripheral arterial disease, because typically claudication, which is pain with movement of a certain distance that's reproducible, usually is associated with arterial disease, but claudication can also occur as a result of deep venous thrombosis, because once you start moving around and blood can come out of the leg, you get acute swelling and you get some pain. And as mentioned earlier, never forget the woman who has chronic pelvic pain. Most of these patients are managed by the gynecologist, who normally do a thorough examination of them. And sometimes they have the vulval varices. So when you look on the inner aspect of the labia minora, you will see these swelling and the patient complain of a heavy feeling in the pelvis, and some of them actually have painful sexual intercourse. So these patients with chronic pelvic pain must always be investigated for venous congestion disorders. Now, this is the stage that we don't want the patient to get to, which is the ulcer. So you ignore the problem for a long time, you will get here. And ulcerations in the legs are very common, right? A lot of them don't need to be as a result of, are not necessarily as a result of venous disease, especially in Jamaica, because we have patients with arterial disease, we have our sickle cell population, we have a huge diabetic population. And all of these patients will present with ulcers, and we need to be able to identify the difference between these ulcers. So this is a classic venous ulcer. And what strikes you as you look on this picture is that the base of this ulcer is healthy. So it's beefy red, as areas are bleeding. The edges around the ulcer are well demarcated, and they're surrounding hyperpigmentation. And if you see an ulcer without surrounding hyperpigmentation, you should raise a red flag in your head that this is possibly not a venous ulcer. And this, the other picture, which is to the right, pretty much just shows the impact of treatment, because this is a patient after 3 weeks of wearing a Una boot, and you can see there's a significant reduction in the size of the ulcer. Still remains healthy, and that white thing that you see on the skin is actually the zinc oxide cream. So as mentioned before, please be keen on identifying the type of ulcer, because ulceration, regardless of the cause, is serious. And most of these patients need to be referred to specialists. So arterial ulcers typically occur on the tips of the toes, the dorsum of the foot, the anterior leg. They typically are very ugly. So they look like somebody just bite out a piece of your tissue. The base of the ulcer is not beefy red as compared to a venous ulcer, because most patients with venous ulcer have very good arterial inflow into the leg. So the base of the arterial ulcer is actually dry, it actually is necrotic, and sometimes there is associated frank gangrene. And when you talk to these patients are often smokers, and these patients are often patients who go from a stage of regular walking to claudication to actually having rest pain. Diabetic or the neuropathic ulcers normally occur on pressure points of the foot, because diabetics have what we call a sensory neuropathy. So they will stand in places for long periods of time, not feeling that the tissue is being compressed, that cuts off blood flow and leads to ulceration. So they're often on the base of the foot, under the head of the first metatarsal. And when the foot changes with time, because diabetics typically with time, with walking, they get changes in their leg. The leg actually becomes more almost like a rocking chair. So they lose those arches, and the midfoot actually now starts to press on the floor, and they walk on the midfoot, and they typically can get ulceration at the level of the midfoot. But these ulcers, again, when you look on them, the base of the ulcer, a lot of times, once it has been cleaned up, does not appear to be without blood flow, and they normally have a lot of callus around the edges of the ulcer. Traumatic ulcer is the easiest one to diagnose, because the patients will give you a history of trauma, and of course, pressure sores in our patients who are bedridden. So if you have bedridden patients, you should always inform the relatives that they need to get air mattresses or ripple mattresses and protect the pressure points, because these patients cannot move around. Because we all know that if you stay in one section of your body for longer than 2 hours, ulceration will begin. Now this picture pretty much shows what we call a C classification, and this is a way to actually classify the degree of the venous disease. It standardizes it across the world, because this is actually used worldwide. And when you see the patients, this is actually, after you finish your history and your clinical examination, you should give them a C grading, so that when somebody else comes to evaluate the patient after you, they can see if the C classification is actually getting better or actually getting worse. So this picture actually, this table actually has been updated, because C4, which are skin change with the ulceration, is now C4A and B, where A is a little bit less than B. B is actually when you start to get lipodermatosclerosis, and A is when dermatitis is present. So C pretty much is clinically what you see. So C0, no clinical signs. And C0 patients are sometimes patients with asymptomatic chronic venous insufficiency. So they get mild swelling in the days, but when they come and see you, there's actually no swelling, because some of these patients will turn up to the doctor's office in the mornings. And that's something that we should always take into consideration. When you see the patients later on in the day, the signs are actually more obvious. So sometimes these patients, if they give you a history and there's a hint in your mind that it might be this, You tell them to go away, walk around for a little while, and come back and let me examine the legs again. And as the C level goes from 1 all the way up to 6, pretty much the signs get worse, where C6 is an active ulcer, C5 is when the ulcer is healed, and C4 is when you have all the skin changes, but there's no ulcer present. E stands for etiology, whether the patient born with a problem that can lead to chronic venous insufficiency, such as Klippel-Trenaunay syndrome, or when it's primary, which is usually valvular insufficiency, or secondary due to a condition such as DVT, as mentioned earlier. Anatomy pretty much breaks down which one of the systems are involved. The deep system, the superficial system, the perforating systems, are all of them. And the anatomy part, sometimes you'll get that information after you send the patients for some form of investigation. And then whether or not the pathophysiology is related to reflux, obstruction, or both. Now there's something called a venous clinical severity score, which is something, again, that must be documented when you see the patients. And what this is a combination of things. So symptoms that the patients experience, what you see, and every time the patient comes, you can take them through this table. And the importance of measuring the venous clinical severity score is that you can assess if your treatment is actually working. Because if your treatment is working, the venous clinical severity score should get less and less with each doctor visit. And at the bottom of the table, you see an example where a patient has pain, 2 has some edema, no pigmentation yet, no inflammation, no induration, no ulcers. And the patient has been started on compression therapy, which they use for most days, and they get a total score of 8. Now, this patient may start to fully comply with compression therapy, and you realize that the venous clinical severity score goes down to 6 or 4, which is some improvement. So as mentioned before, it's pretty much developed to evaluate the changes that occur over time and in response to treatment, right? And it can be generated by the clinician at each visit. And remember, especially for us doctors who work in the public system, every time the patient comes to the clinic, the patient will see a different doctor. So these things are very important to document in your notes, because there's no way you're going to know if this patient is getting better or getting worse unless these things are documented. Now, once clinically you have made the diagnosis, then the next step is to get some investigations to confirm your suspicion or to find out how bad this condition is. And the #1 test is usually a venous duplex ultrasonography. A lot of our patients are sent for venous Dopplers. Now, when you send a patient for a venous Doppler, you're going to get back a report that says no DVT, and that's it. And that's not helpful. So you should indicate on the form duplex ultrasonography. Duplex stands for doing 2 things. They want to check size and structure of veins, and they also want to check whether or not there's reflux and whether or not there's obstruction. And the importance of this is that you need to get back a test that you can interpret to know how bad this condition is, and if this is a condition that you need to refer your patients to a surgeon, or you can continue the management of the patients. Radiologists a lot of times do not see patients as clinicians, so they're going to follow the orders that we write on the paper. There are some radiologists who will go ahead and do the duplex because they can recognize that what you're trying to find out is information about venous insufficiency, whereas some of them will just do the Doppler and send back the patient. And then now you are going to have to send back this patient to the same institution to do the test, and patients are going to get upset and angry because they have spent money already, and the duplex is going to cost them more. And sometimes you have to just sit down with the patient and calm them down and let them know that how important this test is. So please remember, the test is a duplex, not a Doppler. Now, when the duplex is done, the radiologist, right, or the ultrasonographer tech who does this test will check for several things. They'll check if the veins are compressible, and if they're not compressible, it usually indicates that there's a clot. And you can get clots in the superficial system as well as the deep system. And they'll also measure the backflow in terms of seconds. And if it's greater than 1 second in the deep veins, it's known as reflux. Less than 0.5 seconds in the superficial system is reflux. And less than 0.35, greater than 0.35, sorry, in the perforators, there's a problem there. So they'll check all of these. And one way to know if your patient had the right test is just to ask them, how long did this test take? And if a patient tell you that they were in and out in 15 minutes, you know it was a wrong investigation, because a proper duplex ultrasonography will take usually more than an hour, right? Because there are several perforators in the leg, they have to go through all the perforators. Then there's a deep system, they have to go through the deep system. Then there's a superficial system, they have to go through the superficial system. And when they go through all of these systems, they need to measure backflow as well as check for compressibility. So this is not a test that can be done in 15 minutes. And if you get a duplex report that took 15 minutes to do, that patient needs to go back to that institution, because there's a problem. They won't be able, that test was not done properly. Now, the information that you want to know which saphenous junctions are incompetent, meaning that the short saphenous junction or the long saphenous junction. You want to know the extent of the reflux. You want to know if there are abnormal veins that are leading to these varicosities. And you want to know the status of the deep system to see if there's any presence of what you call a DVT. So look for these things when you get back your report. You want to see the status of the short and the long saphenous system. You want to see the perforators. You want to see whether or not there's a DVT, and you want to see whether or not there are any abnormal veins that are leading to this problem. Now, CT scans and MRIs can also be used to get information on the veins, but this is actually more important if you scan the patient's leg with duplex ultrasonography and the clinical signs and symptoms that the patients are complaining of does not match the report that you have. It can mean that the problem, which is obstruction, is at the level of the pelvis, and duplex ultrasonography is not good to assess pelvic problems. So these patients, you have to send them for a CT or an MRI to see what is happening in the pelvis, especially the patients who have been referred or patients who have been seen by a gynecologist for chronic pelvic pain. So with contrast, venography can either be done ascending or descending depending on which veins you puncture and introduce contrast. One of the problems with contrast venography is not usually done a lot anymore, because actually puncturing these veins can actually lead to damage to the veins and can lead to thrombosis. So it's actually good that the majority of our patients, more than 90%, can be diagnosed with a duplex ultrasonography, and we can avoid these invasive tests. Now there's intravascular ultrasound, which are done in specialized centers. And pretty much what this is actually you putting a probe into the deep veins and carrying the probe all the way up in the pelvis. So it's more important to diagnose, again, just like CT and MRI, pelvic venous disorders. And what we are looking for is usually obstruction. And the good thing is that if the legs are fine otherwise and there's obstruction in the pelvis, this obstruction can be stented. So stents can also be placed in veins. And a lot of times if you see a patient with unilateral disease, especially if it affects the left lower limb, it can be because of compression of the common iliac vein by the common iliac artery. Something called May-Turner syndrome. And once you put a stent that pops these veins open and takes off the pressure from the artery, the patient improves significantly. And these stents actually work and they remain patent for many, many, many years. Now, after you have made a diagnosis, the next step is treatment. So all patients, and I'll say it again, all patients with signs and symptoms of chronic venous insufficiency should be initially treated with conservative management. And conservative management, usually the gold standard is the use of compression stockings. And most of us are familiar with compression stockings. They're readily available. And once the patient starts to wear them and shows compliance, they normally get improvement. And of course, from your history, risk factor modification is actually very important. So if your patient is overweight, sedentary, you need to fix all of these. Stop the smoking. Oh, that's the hardest thing to get patients to do, stop smoking. Most time a patient will only put down a cigarette when they actually find out about cancer, or they actually end up on an operating table for severe vascular disease. And even with this, a lot of them continue to smoke. There are a few patients who will tell you that the problem is there already, they need a cigarette. But a lot of times if cigarette smoking continues, the problem continues to get worse, especially if there's concomitant arterial disease. Now this is a flow chart. You see the patient, their signs and symptoms of chronic venous insufficiency, you start them off with stockings. Now stockings come in various sizes and they come in various compressions. There's 15 to 18 millimeters of mercury, there's 20 to 30, there's 30 to 40, and there's 40 to 50. Those are the common ones that we see. The majority of patients will improve just by wearing a 20 to 30. Usually the 15 to 18 millimeters of mercury, we use that as prophylaxis. So like for operations, we'll put patients in these stockings if they need to go on an operating table for a major operation, especially one that involves the use of muscle relaxants that can result in pooling of blood. But usually once they have signs or symptoms of chronic venous insufficiency, we can start them off on a 20 to 30. And the majority of patients will show improvement with this. So if you get a satisfactory response, you can continue treatment. But I still send the patients for duplex ultrasonography to see what we're dealing with, to see if these patients can just continue like this, or we can intervene to make them get better at a faster rate. If you get an unsatisfactory response, now an unsatisfactory response can be as a result of non-compliance. So compliance must always be checked. And I'll tell you the commonest reason for non-compliance that the patient can put on the stockings. Patients complain bitterly about how difficult these stockings are to go on, and then can't bother, and them need help. And sometimes when they wake up, the help is not around, and they'll tell you all of the excuses in the books. So I personally have leg swelling on my long days. And so sometimes when I'm in my office, I have on my stockings. And when they start to talk, I just lift up my pants foot and show them. And they say, I put on mine. And a lot of times you'll realize they just don't put them on because they can't be bothered. Some women will tell you that they're not going to wear the stockings because the outfit they have to wear for that day, the stockings is not going to make them look good. Tell them to wear a pants. A lot of times when you show them what can happen, meaning that an ulcer, the compliance level actually improves. As well as when they start to feel worse enough their symptoms, then they will start to wear the stockings. So if there's unsatisfactory response with compliance, then further investigation must be done as you see. So venography, the duplex actually will give you the information on the majority of patients. And if you think your patient has muscle pump dysfunction, you consider exercise program. Exercise program will actually help, but if you have valvular insufficiency already, it's not going to make the symptoms improve. So you have to use a combination of the exercise with the use of compressive therapy. Right, so as well as when we order stockings, most times there's no need to order stockings that go above the knee or the ones that form like a pantyhose. The higher up the stocking goes, I'll tell you, is the worse the compliance. Because if you think it's difficult to put on a stocking that stops at your knee, try putting on a pantyhose that goes up to that level. Most men probably won't understand this, but the woman will tell you, it's extremely difficult to put on a compression pantyhose. And when they put it on one time and take it off, a lot of times it's not going back on. So they don't need to put on a pantyhose most time. The compression at the level of the knee will actually help, because if you remember, when you stand, the highest pressure is at the level of the ankles, and this is where the help is needed. And when it comes on to compression garments, apart from stocking, we also have non-elastic compression, such as Una boots, which doctors put on, or layered bandaging, which they do in some of the clinics. I don't know about the clinics in Kingston, but in Montego Bay, we have started a program in almost all of the clinics that do dressing, where we address venous ulcers specifically, usually with the use of compression bandaging. We have had donation of Una boots, which we use on the patients, and the nurses are taught how to clean and dress venous ulcers and apply these Una boots, and we are seeing good results over the years, right? And of course, with a structured regime of compression therapy, most patients will improve, and you can get up to a 90% ulcer healing rate in about 5.3 months. However, once the compression therapy is stopped, the ulcer is going to come back if the underlying problem has not been addressed, either by some form of intervention or open surgery. As said before, the amount of pressure you need is based on what you have. But 30 to 40 and 40 to 50 is very difficult for patients, very difficult for patients. But if they can, you can wear them, but they are extremely tight. And a lot of patients, because of the discomfort, they won't wear them. So choose a lower strength and encourage compliance, and we'll see the benefit of it. Now, stockings, they wear out after time, and all depends on the brand that you buy. So I normally encourage patients to get more than one pair. If you can get two, you wear two. You have two, because you can wash one, and while one is being washed and dried, you have the other one to wear. And if you wear two interchangeably, they will last longer than if you only have a single pair. And if you have a single pair as well, compliance is going to decrease, because if you take it off and it smells funny, you're not going to put it on the next morning if you're not dry. And the patients who have ulcers, a lot of them blatantly or adamantly refuse to wear their stocking, because in Jamaica, if you have a cut and you cover the cut will go boil up. That's what they say. And if the cut boil up, you're going to get bigger. And we don't want the ulcer to get bigger. But you have to reassure the patients that without compression therapy, the ulcer will not heal. So without compression therapy, the ulcer is going to get bigger and bigger and bigger. Reassure them that this boil-up thing is rubbish. It's rubbish. And even if they still are resistant, make a little bet with them and say, just wear it for a week or two, and let's see what happens. And a lot of times, you have to take pictures of this ulcer, because they won't notice it, you know. Take a picture of the ulcer and take a picture after 2 weeks, and when you show them, and they see the healing around the edges, it will improve their compliance. As well as they will tell you, the weeping from the ulcer is less, they feel better at night, and the patients who need to get dressings, because there's less weeping, they smell better, they can take public transport, their quality of life improves. They can now be around their friends, them can go hang out. But those who want to sit and drink at a bar or have a coffee, they're more likely to do this. And it doesn't matter what you do, quality of life is extremely important, because if you have quality of life, you'll have longevity. So you have to try to get your patients to a point where their quality of life is restored to them and they can continue living. It's not good to be sitting in a house with an ulcer that smell and suffering from depression, right? So speak to the patients and spend time with them to reassure them that this thing can get better. Just follow what I'm telling you, and together on this journey, you're going to get better. Now, which patients you must not put in stockings? So this is again why it is very important to sit and talk to your patients and get a proper history. So patients who have concomitant peripheral arterial disease, for some reason, it is not so common to have both these diseases together. So if you have concomitant disease and your ABI, which is your ankle brachial index, which is something that we calculate in office or in the clinic by dividing your systolic blood pressure at the brachial level and the ankle level and getting a value. If it's less than 0.6, you shouldn't put them in compression stockings, because compression stocking is going to further reduce inflow of blood and will worsen the peripheral arterial disease. Similarly, if you see a patient with an arterial ulcer, an arterial ulcer is a clear indicator that your ABI is usually less than 0.6. Don't put these patients in any stockings. If patients have arterial disease as well and have had surgery, a lot of times when we do arterial bypasses, especially if we harvest the saphenous vein to use, or if we use a graft and this graft is not reinforced, we tunnel these grafts under the skin. So you actually can put your hand on the patient's leg and feel them. Now, if you put on a tight enough stocking on those, it's going to fracture the graft or compress the graft and cut off blood supply. So speak to the patients. Patient with severe heart failure, patients who have allergy to compression material, and some patients get a significant amount of itching from these stockings. But a lot of times it's related to dry skin. And once they start to lubricate the skin properly, usually with lotions, usually with oils, the itching reduces and the compliance improves. So I've never really seen somebody with a true allergy to compression material. The ones who have stopped wearing it because of the itching, a lot of times, once they start to put these things on their legs, they start to feel better, the itching decreases significantly. A few patients, you may have to put them on some antihistamines, but that's not common. And now patient with severe diabetic neuropathy. Now the diabetic population in Jamaica is very large, very, very large. And if you realize that these patients have a sensory deficit, you should not put them in stocking, because if you put them in stocking, they're going to end up with pressure ulceration. Because if a normal person puts on a stocking and it is too tight, the skin is going to start to burn them. And they're going to feel like somebody throw fire onto their feet. And they'll take it off. A diabetic will not be able to feel this. And when the stocking comes off, they're going to end up with multiple ulcers. And these ulcers can just lead right down a path where they end up with amputations. Skin and wound care is very important, right? The skin must be clean, must be moisturized. Sometimes steroids are given to the patients who have dermatitis, and the type of dressing that you use to control infection in these wounds. You know, generally venous ulcers are very resistant to infection. They become colonized because of the large amount of granulation tissue there, but they're rarely infected and rarely lead to associated cellulitis, right? But proper dressings are needed, especially when ulcers occur, and proper dressings before you put on the compression or before you put on a Una boot. So when we see the ulcers, pretty much we try to remember what we call time. If the tissue needs debridement, if there's any form of infection or inflammation, we will treat this. Moisture balance, which is usually related to the dressings. And sometimes when the ulcer is just meeting the patient and the patient has not started any form of therapy, especially if there's significant edema, you know, their dressings need to be padded more than the normal patient who is compliant, because they're going to lose a lot of fluid through this foot. And then you always check the edges of the wound to make sure there are no changes. Now, there's something called a Marjolin's ulcer, which is an ulcer that you get from a long-standing venous ulcer. And what happens is that the chronic inflammation leads to dysplasia and leads to squamous cell cancer in these wounds. And this must not be missed. If this occurs, or if you see an ulcer and the ulcer looks angry and you're not too comfortable, refer this patient to a surgeon for assessment. Because if you leave untreated squamous cell cancer, patient is going to die from metastatic disease. Now, pharmacology plays a major role, and it's usually done hand in hand with the use of compression therapy. And there are several drugs that are available for use. And of course, the most popular ones are the micronized purified flavonoid fraction and pentoxifylline. So pentoxifylline is a drug that's used for both arterial and venous disease. And pretty much for venous disease, it helps with inflammatory cytokine release and leukocyte activation, which occurs in the subcutaneous tissue. It also reduces platelet aggregation, and pentoxifylline actually helps red blood cells to become a little bit more deformable, to move through the system, your venous system, a little bit better. And the micronized purified flavonoid fraction is very good. It helps with inflammation as well. And once patients are placed on these drugs, a lot of time they get symptom relief, even in the absence of the use of compression therapy. So veno-active drugs, they play a big role in the treatment of these patients. And when you read the clinical practice guidelines, there's a moderate recommendation for these drugs to be used. Now, exercise is very important. Whether you're ill or not, you're supposed to exercise. 30 minutes a day, 3 to 5 times a week. It keeps your muscles up, keep your muscles strong. And if you're strong with your muscles, you're strong for life. If you need surgery, your strength helps. If your calf muscle is strong, you get a more efficient second heart. If you have a more efficient second heart, you pump blood out of your leg much more readily. Ambulatory venous hypertension will not occur. Now, when the patient ends up to the surgeon, these are some of the modalities that are available to us for treating these patients. Sclerotherapy, endovenous ablation, endovenous deep system treatment, and open surgery. You notice open surgery is at the bottom because it's the last resort, but Jamaica is a third world country. A lot of our public hospitals don't have sclerosants available, and we don't have endovenous ablation therapy available to our patients. So we still have to do open surgery. And as bad as open surgery appears in the light of the first world, it is not as bad for the third world patients because they do very well after open surgery. And even though people may think that the cosmetic outcome is far inferior as compared to the others, it is not. Because these incisions nowadays are very small and patients heal readily, and you actually help to reduce the venous hypertension and heal their ulcers. So don't leave a patient and tell them to go and save for 6 to 8 months or 2 years to go and get endovenous ablation. If they can afford it, yes. If they have insurance, yes. But don't leave them in the wind when open surgery is also available to them and they can get it in the public health system and improve and get a better quality of life. Now, sclerotherapy pretty much is the use of medications that mixed outside the body and injected into the veins. It can be done freehand or it can be done with the use of ultrasound. Now, the use of ultrasound makes it more accurate. And as well, when you use ultrasound, you can actually use the ultrasound probe to compress the vein so that the sclerosant makes proper contact with the walls of the veins. And what the sclerosant does is to destroy the walls of the vein and lead to sclerosis or fibrosis of the vein and sealing of the veins. And the two most popular agents that we use, which you see in red, which is sodium tetradecyl sulfate and polidocanol, they're very effective, right? And they're used a lot by dermatologists as well to treat spider veins. And if you have ever seen this, one injection and the spider vein disappears totally in front of your eyes. It's almost like magic. But the bigger veins is less effective, of course, because of contact with the vein wall. And the problem if the vein is too big, you need to be careful because the foam can actually get to your deep system and embolize. And if it embolizes, it carries the same sequelae as a clot. So you have to be careful when you're using it. So it's very good for spider veins, very good for venous leaks and varicose veins that range from 1 to 4 millimeter. It's very good for bleeding varicosities. If you have small cavernous hemangiomas, and what if the great saphenous vein diameter, which we normally measure when you do the venous duplex, if it is greater than less than 6 millimeter, it is more effective. So the smaller the vein, is the better the effectiveness of sclerotherapy. Right? The only problem that we see with sclerotherapy most times is that the patient may get some amount of hyperpigmentation. But reassure the patient, the hyperpigmentation is going to disappear. Now, a patient coming in with hyperpigmentation because of the venous disease, and you're going to give them more hyperpigmentation, that doesn't sit well with a lot of patients. But with reassurance, they'll undergo it. And once they see the resolution of hyperpigmentation, they start to feel much better. So it is very good. As I said before, you get a good relief of pain. You stay out of work longer. You stay out of work for a shorter duration of period. But because of the effectiveness of it, the recurrence rate is a little bit higher than the rest of treatment. So it's actually lower down on the choices that we'll make for a patient if you want a better outcome. Now, this is pretty much a gold standard that's done now for varicose vein, which is endovenous thermal ablation. All this means is that something is put inside of the vein and the vein is burnt. And while you burn the vein is sealed. So there's no cut, there's no ripping of any veins out of your legs. All you get in terms of scarring is a needle puncture wound, just like you have had a branula or blood taken from you. So the cosmetic outcome or the cosmetic effect is very good. So for patients who have short and long saphenous vein insufficiency, it's excellent. And ultrasound is used to cannulate these veins. A probe is placed, the probe is carried all the way up to the fossa ovalis, which is in the region of the groin. You withdraw a little bit, usually about 2 inches, and the sealing starts come all the way out. And for most probes, they seal like about 7 centimeters at a time. So a sequential sealing, and this is done in the office, or it can be done in the operating theater. You don't even need a general anesthetic. We use what we call tumescent anesthesia, which is a large volume of lignocaine, adrenaline, sodium bicarbonate. And what we do is to use the ultrasound to inject around the vein, and pretty much it seals or separates the vein from your normal tissue, especially the nerve that run with these veins, and you can seal the vein and the patient pretty much is very comfortable during the procedure. And once the procedure is finished, the patients go home and they can return to work usually in about 2 to 3 days. So when it comes on to great saphenous vein ablation, radiofrequency ablation carries an 85% occlusion rate at 2 years. And recanalization occurs in about 11% of patients, with 95% of patients reporting satisfaction. And with great saphenous, with endovenous laser ablation, the outcome is a little bit better. They get 93% success at 2 years, and the DVT incidence from both of these procedures are very, very, very low. And of course, quicker return to work, quicker return to activity, improve quality of life in these patients. And for the patients who have ulcers, that are directly as a result of the superficial or the perforator system, they get quick healing of these ulcers because the venous hypertension is ablated at the time when these procedures are done. So this is a little picture with one of the cases that we did at Corner Regional Hospital with equipment that was donated, right? This patient is in the operating theater, and as you can see, there's an instrument that's inside of the great saphenous vein. It's Dr. Rogers who actually has the ultrasound here. She's one of our radiologists. And pretty much what she's doing is just monitoring the passage of the probe up into the vein before we start sealing. And this patient actually did very well. Now, one of the common complications with thermal ablation is burning, because of course, radio frequency and laser delivers heat. And you can protect the patient from proper tumescent anesthesia. So you actually have to watch under ultrasound guidance while the fluids surrounds the vein within its fascia, so that once the heat is delivered, the heat does not traverse through that fluid and onto your tissues. So even though burning is a complication, it is not very common, right? And damage to the nerve as well is not very common once it is done properly. And damage to the nerve is something that must be discussed with your patient, because it's actually the #1 reason why patients end up with lawsuits from this procedure. And when this procedure was just started, between 10 to 30% of patients used to get saphenous nerve injury. And if you've ever had a nerve injury before, it really changes your quality of life immediately. You get pain that a lot of painkillers can't help. For patients who get numbness, and numbness bothers them significantly, because your inner thigh is somewhere that, even though you think that your inner thigh does not come in contact with the world, for some people, it's one of the zones that they enjoy when they partake in sexual activity. So a woman will always notice if numbness is in her inner thigh. So it's very important, because the majority of patients that we see with venous disease are women. This must be discussed with them, the risk of it occurring. And we try our best during the procedure to administer enough tumescent anesthesia to prevent this from happening. Now, in terms of deep system therapy usually involves the use of stenting. And this is usually for patients with pelvic venous obstruction. In some specialized centers, they can actually repair the valves, and they can actually transport veins from one section of your body to the next. Like they will take out your brachial vein or your axillary vein and put it into your leg to pretty much move valves into your system that is affected to reduce reflux and improve symptoms. But of course, apart from stenting, valvular transfer is not a popular procedure done because of the associated cost and the associated risk. And a lot of times when you tell a patient that you need to give them one cut somewhere to put another cut somewhere, they blatantly refuse it. Now, open surgery is what we do most commonly here in the public system. And pretty much what that involves is a 3 to 4 centimeter incision in the groin. You ligate all of the tributary that goes into the long saphenous vein. And we make another cut usually just below the knee or above the knee, which is usually a centimeter. And this vein is removed from the leg. The leg is bandaged, and the patient is actually sent home the same day. They keep on that bandage usually for about 3 days, and then they resume wearing of them stockings. And this actually helps a significant amount of people. They do well. And just how the ulcers heal with endovenous ablation, they heal with open therapy. So as I said before, even though it's not gold standard, don't throw it away. It helps our patients. And our patients actually don't complain much about a 3 and a 1 centimeter incision. They're fine with it, because these are incisions that actually don't show, right? And a 1 centimeter incision close to the knee or below the knee, which is the one that's actually exposed to the public, is very hard to see, right? Now, if we have to ligate perforators, those come with additional incisions. But again, they heal so well that the patients often don't have a problem with them. And stop phlebectomy pretty much is what we do, is to make small incisions, usually about 0.5 centimeters, and we hook the varicose veins and actually just pull them out of the leg. And we bandage the leg after, so those unsightly veins are gone from your leg. You get a little bit of bruising after this procedure, but the bruising usually just disappears with time. Valve reconstruction, as I said before, done in specialized centers. Rarely, I don't know if this has ever been done in Jamaica, but it's rarely done in is usually done in specialized centers to help patients who are usually resistant to other forms of treatment. Now, if you compare all of the treatment modalities that mentioned earlier, the gold standard is endovenous laser ablation, followed by radiofrequency ablation, and then high ligation and stripping. But all of them are equally effective. They are separated usually by patient outcomes and patient quality of life and immediate effects that the patients will tell you, and the fact that patients don't have to leave work. Funny thing is that when you read studies from first world countries, loss of work days is very important, but a lot of patients in Jamaica, they want to extend their sick leave. They don't want to go back to work. So when you tell them things like this, they really sometimes don't mind taking a week or two off from work. But in the global picture, any treatment modality you administer, you want your patients to go back to work as quickly as possible, right? And endovenous laser ablation, of course, the intraoperative bloodless is less, there's less operating time, and there's fewer complications. Now, disease can also recur after treatment, especially with inadequate intervention. So if your surgeon performed the procedure and there are technical errors, neovascularization occur, which pretty much you have new veins. Some patients have duplications of their superficial system. So they may have two long saphenous veins. They may have an anterior saphenous vein that's missed, and you ligate one or ablate one, and the other one is there and leads to recurrence of the symptoms. So proper investigation is actually needed prior to treatment to reduce the incidence of recurrence. And of course, we are humans. You may miss the problems. And these are my references. Thank you.
Mic check. Okay. Thank you so much, Dr. Hall. What more can I say? That was really, really a very extensive and comprehensive, all the adjectives that suggest that it was well received. And I know there's questions, so we'll allow for some time for some questions. So we'll take questions from the floor as well as online. So you know the usual procedure. You can go to the floor where the mic is and ask a question for Dr. Hall.
All right, thank you very much. Again, wonderful presentation. First question, does flavonoids offer any clinical benefit once clinical signs of CVI are present, or is it more of a placebo effect for patients?
Well, when I spoke
Dr.
about
Hall, do me a
the
favor
use,
and just turn on your camera as well?
it's not allowing me to say the host has stopped my video.
You should be able to. Go ahead.
Right, I can, it's on now. So the use of flavonoids actually, it's not a placebo effect. So research has shown that patients have improvement in clinical symptoms with the use of flavonoids alone, even in the absence of the use of compression therapy. But compression therapy actually is the gold standard when you start conservative treatment, and flavonoids are not usually used for an extensive period of time. Most patients will take them usually for about 3 months. But in the absence of every other modality, there is effectiveness.
Thank you very much. Dr. William Brown asks, how do temperature changes affect initiation of varicose veins, especially in persons with prolonged standing jobs?
Temperature changes? You mean whether you're living in a temperate country or live in a tropical country? I don't think that the temperature changes, I don't think the temperature change really has much effect on it, because, I mean, whether your external temperature changes, your internal body temperature usually remains about the same. So as far as I know, and as far as some of the research I've done, I've never seen an effect on temperature, whether or not you live in a cold country as compared to a warm country.
Okay, thanks. So then, does the hyperpigmentation reverse with the management of the venous congestion?
Well, that's one of the most difficult things to reverse. I usually tell the patients that we're more likely to prevent further hyperpigmentation than reverse this. But with long-standing use of the compression stocking, the hyperpigmentation becomes less obvious. But it takes many, 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 many years. It's not an overnight thing. So if you put on a stocking for 6 months or a year, the hyperpigmentation is not going to change significantly.
Okay, thank you. Dr. Heyman asks, is there a formula to calculate the degree of compression when choosing a stocking?
No, you don't really need a formula. The degree of compression that you choose is based on the leg that's in front of you. As I said earlier before, it depends on what you have. When you the further up the C class you go, is the higher the compression that you need. So for patients with C1 and C2, you use a 20 to 30. When you get to the point where you start get lipodermatosclerosis, you need a 30 to 40. And if you have an active ulcer, especially if it's resistant to treatment, you can go up to 40 to 50. But patients are not going to wear those. So the 20 to 30 is satisfactory for most patients. And I must add that the patients have to get their legs measured. They can't get stockings from their relatives in America or go on Amazon and order a stocking without doing the measurement. So you have to measure your leg, and you need to measure your leg when the edema is gone, or else you're going to get the wrong size. So you'll get the right compression, but the wrong size. So you get ineffective compression. So the patients have to get the right size and the right compression for clinical changes to be seen. And that's very important. Okay. So if you want to tell them to do the measurement yourself, if you want to let them measure it yourself, you tell them to measure just around the level of the ankles, of the medial malleolus. You let them measure the mid-leg level, and you ask them to measure the top of the calf muscle. And you get 3 measurements, and these 3 measurements can be used to order a stocking. And you must do these measurements after the edema has settled, or you're going to get a stocking that's too big.
All right, thank you so much. So no Tommy John, no copper, Amazon copper stocking. All right. What about the use of compression stockings in someone who also has arterial disease?
With arterial disease, there was a slide that actually indicated this. So if you suspect that your patient has peripheral arterial disease or arterial occlusive disease, you pretty much should measure the patient's ABI. And if the ABI is less than 0.6, these patients must not be placed in compression garments, because it will further reduce arterial inflow and worsen their peripheral arterial disease. So that's why you must take a thorough history from your patient and spend time with them to find out if they also have arterial disease, especially if the risk factors are in front of you. So if they're diabetic, if they're hypertensive, if they're smokers, and if they have a history of hypercholesterolemia, then these patients are actually top of the risk stratification level to get arterial disease as well. So once you suspect it, do the test on the leg, which can be done in your office. And if you get ABIs of less than 0.6, these patients can't get compression stocking, and you should refer them to a vascular surgeon.
All right, so I'm gonna merge 2 questions here. Part 1, someone would like your opinion on zipped compression stockings. But part 2, another person is asking, what are your thoughts on leg massagers as an additional therapy for venous insufficiency?
So zipped compression stockings work just as the ones that come without a zipper. The only thing is that you need to be careful when you're pulling up that zip, or else you're going to injure your leg. Because I've seen patients come with lacerations from the zippers. So you have to be careful, but it works just the same way, and it's a little bit easier sometimes if you don't have help to put on the stockings, especially the ones with a high compression. And in terms of leg massagers, yes, leg massagers actually help, especially the ones that can simulate you walking. So you put them on and they actually pump the legs at different levels at different times. So they actually help to get blood out of your leg and will actually help with improvement of some of the symptoms. In fact, remember pneumatic compression stockings, which we use for patients that are undergoing very long operations, especially if you can't give them DVT prophylaxis. This is actually what it does. It simulates walking. So it reduces the venous hypertension in the leg.
And wait, did you answer the leg massages part?
I did.
I apologize. Thank you so much. All right. Can compression stockings be worn at nights? And I mean at night when you sleep.
So the only way you should wear compression stockings at night is if you sleep upright. Once you sleep lying down, you don't need them. Because once we lie down, our pressure in our legs, they're at the level of the heart, it actually goes to zero. And this is why most of the symptoms resolve during sleep. So if you have to sleep standing up, yes, you need it. Otherwise, take them off when you're going to your bed at night.
All right, thank you so much. We have time for one more question. Let me see if I can get a question on YouTube, because we have about 250 of our colleagues on YouTube. So let's see if they have any questions for you over there. Nope, just a wonderful comment that you're an impressive doctor and they have not seen you in a long time. So ladies and gentlemen, a round of applause and thanks to Dr. Dwayne Hall. We thank everybody for their questions online. We appreciate it. We will try to forward the questions that weren't answered to Dr. Hall so that when he's free, he can offer some answers and we'll try and share them. Back to you, Nakia. Thanks, Doc.
Thank you so much, Dr. Hall. Okay, so we are moving into a very unique, I would say, part of our journey throughout this day that we've had so far. And that is, I would consider the best hour day. In other languages, we refer to it as la comida. Is that correct? So we're gonna have good food. The happiness sounds like lunchtime to her. And whenever she's fed, I want my audience to be happy. And I don't want you to count the calories, guys. I want you to just count the memories that we're having here today.
Well, good afternoon, everyone. Good afternoon, Prof. Bailey. Prof. Alverston Bailey is well known to the medical community in Jamaica and in the wider Caribbean also for a number of reasons. A graduate of the University of the West Indies with his MBBS degree in 1980, he went on to pursue postgraduate training in occupational medicine from the American College of Occupational and Environmental Medicine, which he has practiced for over 4 decades. Domiciled on the north coast of Jamaica, he served as the Chief Medical Officer for Kaiser Jamaica Bauxite Company, while he served as their occupational physician and medical review officer. In 2010, he was appointed as Adjunct Associate Professor in Occupational Health and Safety at the University of Technology, where he lectured in the new academic program, the Bachelor of Science in Occupational Health and Health Technology. He had a specific mandate to design and deliver the occupational health modules. Professor Bailey has also served as Associate Lecturer at the Caribbean School of Medical Sciences, Jamaica, since 2016, and was appointed to the position of Executive Vice Dean recently in July 2023. Professor Bailey has served in a leadership role in several of our medical associations locally and regionally. He is the past regional president of the Caribbean College of Family Physicians, a past president of the Medical Association of Jamaica, and currently serves as the chairman of the Medical Foundation, which does charitable works. Prof has also been the recipient of the Medical Association of Jamaicans President's Award for his role as a family physician in 2003, and he was made a fellow of the Caribbean College of Family Physicians in 2006. In April last year, he was conferred the Sir Alistair McIntyre Distinguished Award by UDOP, University Diabetes Outreach Program. He is currently the co-chair of UDOP and has worked closely with the Diabetes Association of Jamaica, and he was appointed its chairman in 2021. We all know Prof. Bailey for his participation locally as a commentator in the media on health issues, and he is also the author of several academic papers, and most interestingly of a book, Sexplanation, a guide to discussing sex and sexuality in the Caribbean. Now, may I add that I will recall, Prof, I will recall attending that book launch held not far from here on an evening many years ago, when I somehow ended up on the podium, as I am right now, singing the Jamaican national anthem. Please help me welcome Professor Bailey to speak with us today on the psychosocial impact of workplace stressors, where he will explore coping strategies. Welcome, Professor Bailey.
Thank you very much for that very touching introduction from my classmate. And I feel unusual standing here. I've not made a public presentation since 2019. I mean, this is absolutely wonderful. Coming here for me this morning, I told my daughter, who is with me, that this is good stress therapy, to once again begin to commiserate and associate with your friends and colleagues. Thank you very much for inviting me to make this presentation. I'm sure that by the end of the afternoon, you will have enjoyed it. And as I was thinking about my presentation, I reflected on the thought that for those of you who are here, and those of you who are online on YouTube, I'd like you to reflect on what I'm going to say and do your own assessment of yourself and determine if you are in fact experiencing stress and need some intervention. So on completion of this lecture, you should be able to define work-related stress and discuss the common workplace stressors. And we will describe some common mental health problems in the workplace, their diagnosis and treatment. I have no disclosures. Now, it is widely recognized that work-related stress is one of the major contemporary challenges facing occupational health and safety. And I intend this afternoon to give you an overview of work-related stress, look at some common mental health problems and intervention strategies. The issues I'll discuss is not only confined to healthcare workers, but to all workers. And I'd like, while I talk to you, to reflect on whether any of these issues are relevant to you in your offices and at the workplace. So, when pressure due to work demand and other so-called stressors becomes excessive and prolonged in relation to your ability to cope, this can lead to stress. And stress is described as a negative psychological state with mental and emotional components and its effect on both the individual, but most importantly, the workplace. So Cox defines stress as a dynamic interaction between the individual and their environment. And I'm particularly keen on you paying attention to what I've put in red, which is the existence of a problematic person-environment fit. It's interesting for me to emphasize this because when I was invited to join the Caribbean School of Medical Sciences as the Vice Dean, I was asked to do a test to see if I am environmentally fit. I called a colleague of mine and said, "What's this all about?" And she said, "They're trying to determine your goodness to fit." So it's interesting for you to pay attention to this concept of person-environment fit, because much of contemporary stress theory finds its origin in the works of Kahn and French, Kaplan and Van Harrison. And they were the one who coined the term person-environment fit. And this argues that stress can arise, and I want you to pause to think about this, colleagues. Stress can arise due to a lack of fit between your skills, your resources, and your abilities on the one hand, and the demand of the work on the other hand. So I want you to reflect, for those of you who are working in government in particular, do you have the ability to fit into the environment in which you find yourself? So the pet fit theory makes explicit the interaction between the individual and the environment. This will determine how you shape your response to work situation, but also highlight the importance of your perception of the environment and the interaction between them. So therefore, at this point in time, do you fit or do you not fit? So the lack of fit is the demand of the work environment exceeding your ability, or the employee's needs consistently fail to be met by the work environment. Or you might have a fit issue if there's a combination of two situations where your needs are not being met and your abilities are being overstretched. And I'm sure many doctors in the public sector and other healthcare providers have had this experience. Another theory is called the job demand control model, or the job demand control support model. And this argues that the job strain you experience result from the interaction between the work environment, namely psychological job demands and job control. Psychological demand is referred to as your workload. More recently, cognitive, emotional demand, and interpersonal conflict have been added to the equation. So job control can be your decision authority, which is your ability to make decisions about your job, or your skill discretion, which is the breadth of skills used by the work on the job. The job demand support theory suggests that those most at risk are those who in fact are not receiving appropriate support. And this is called stress due to lack of support, and it has an interesting name. It's called isostrain. So another theory called effort-reward model was developed by Johans in the early 1990s. And this theory, and this is something that a lot of doctors in the GMDA will understand. This theory assumes that effort at work is spent as part of a psychological contract based on social reciprocity, where your effort is met with reward, such as money, esteem, and career opportunities. And most of the time when I hear GMDA arguing about challenges at the workplace, it really is because of lack of social reciprocity. Now, if there's no reciprocity between the effort spent and the reward received, this causes emotional distress. Now, this particular model assumes that the employee has a poorly defined work contract, and that is seen very often in the public sector. But the employee might accept the imbalance, or the employer might just become overcommitted. The transactional model suggests that stress is a result of a dynamic interaction between the individual and the environment. That is, stress results where the perceived demands outweigh the ability of the worker. This particular model is influenced by your personality, the situation in which you find yourself, your coping skills, your previous experience, and any other stress you're going through. If you look at the next slide, a lot of studies have been done on stress, and I cite some studies from Europe, which indicate that 22% of workers from the 25 member states are experiencing stress. Greece had the highest stress level, followed by Slovenia, Sweden, and Latvia. I wonder what the stress in Ukraine now is. The European Commission reported in 2002 that the cost of work-related stress was over 20 million euros, and that 50 to 60% of all lost work days have linked with stress. At a national level, stress has been found to have significant and real costs to employers and to society. In Germany, the cost of psychological disorders was about 3,000 million euros. In the UK, an estimated 70 million working days are lost through poor mental health, and 10 million of these are the result of anxiety, depression, and stress. So what are the exposure factors at the workplace? The factors are stresses intrinsic to the job, the role you play in the organization, the quality of relationships at work, the career advancement or lack thereof, the organizational structure, and a very important issue having to do with a balance between home and work. The stress reactions that one might experience are reduced attention and perception and forgetfulness, feeling nervous or irritated, aggression, impulsive behavior, or recurrent mistakes. Many of us, when we're stressed out, have a physiological response with increased heart rate, increase in blood pressure, and hyperventilation. I thought I'd share this law with you. It's called the Yerkes-Dodson law, which actually was postulated a long time ago. It suggests that for any particular task and worker, there is an optimum level of arousal at which performance is at its maximum capacity. And a lot of surgeons in particular can relate to this, and young junior doctors, is that if the task or stress goes beyond a particular level, your performance will decrease. And that's what it looks like. Too little stress, optimum stress, too much stress, and extreme stress result in burnout. Now, there is another concept I want to share with you. And for those of you who work in the public sector, one of the take-home points I want you to raise with your HR personnel is a concept called organizational healthiness. The health impact of psychosocial risk and work-related stress extend beyond the individual and can affect productivity, resilience, and it is called organizational healthiness. This means that your state of mind will determine job satisfaction, morale, and an interesting concept called presenteeism, which I'll talk about shortly, and organizational commitment. So as I mentioned, long-term stress will cause fatigue, burnout, musculoskeletal problems, and heart disease. Now, there is a link between work stresses and work strain. So let's just look at some definition. Work stresses are demands that workers perceive as threatening, example, certain tasks and roles, conflict, and some management action. Whereas strain are the negative response that result when such demands are in excess of your coping skills. Therefore, stress, to emphasize the point, is a dynamic process in which physiological and psychological manifestations relative to a perceived imbalance between work demands and ability to cope occurs. And of course, it results in a variety of issues. I want to introduce you to this study, which actually was done a long time ago by Head et al. It's called the Longitudinal Whitehall 2 study. And it shows some interesting things. If you are not actively involved in decision making, what they found was that it leads to obesity, alcohol dependence, impaired mental health, poor health functioning, increased sickness absence, and heart disease. If your job demand is very high, and this is quite interesting for those of you who work in the health sector, especially in the A&E department. Job high demands can result in obesity, poor mental health, impaired health functioning, and heart disease. And inadequate social support, and notice obesity turns up repeatedly, results in obesity, poor mental health, impaired health functioning, and increased sickness absence. And I think I'd like you to pause to look at this one, especially those who work in the public sector. High effort and low reward can lead you to alcoholism, poor mental health, impaired health functioning, long spells of absenteeism, diabetes, and heart disease. Interesting stuff. So let's just now take another look at some psychosocial hazards. I want to introduce you to the concept of absenteeism. Absenteeism, basically, third most commonly cited reason for absence in a study done in Australia, with 18% of workers identifying anxiety, stress, or depression as a cause of work absence. What about presenteeism? That's someone with a fake smile. It is defined as decreased productivity and below normal quality work that occurs due to health problems when employers are physically present in their jobs but mentally in another space. And it has been shown actually 2.4% of work stress can be caused by absenteeism. But what I found quite interesting when I look at literature is that being present at work is oftentimes worse than being absent. So that's something for us to reflect on. Other outcomes can be rapid turnover or attrition, elevated compensation costs, negative customer service. A lot of time is spent with conflict management and the need for training and employee assistance programs. I want now to just go through some interesting psychosocial issues at work, and many of you can relate to these. Time pressure. Time pressure or overload refers to the requirement to work very hard or very fast to meet key performance indicators. Cognitive demand. These are tasks with high cognitive load or with low cognitive load that can lead to stress. Emotional demands. Job requiring workers to show false display of emotion, like happiness when you're not happy, or desire to please when you'd like to displease, is stressful. Hours of work, and all of us as healthcare professionals can relate to this. Poorly designed work schedule can create risk to health due to exposure time. Many hours of work may dictate how long you're exposed to psychosocial hazards in a given week. Fatigue. Hours of work and shift design can lead to fatigue, which then indicates injuries and near-miss accident, sickness and absenteeism, and poor work-life balance. Your roles. Role conflict and ambiguity refers to workers understanding their role within the organization or not understanding it. Conflict. Interpersonal stresses. Styles, absences at work. Change. Change is stressful. There's a large amount of research which suggests organizational change is a work stress. Occupational violence and workplace job control. Who is the boss? This actually refers to how much say people have in the way they do their work. Worker and supervisor support. One characteristic of work, it has been extensively support in which you provide practical assistance to solve support, such as listening and understanding. I thought this particular stressor was interesting, called organizational justice. Are you being treated fairly or unfairly? So we have procedural justice, in which the perceived fairness of procedures used in workplace is challenging. Distributive justice, in which the perceived fairness of decision outcomes, i.e. the rewards are commensurate with effort, who gets selected for particular posts, and interactional justice, which has to do with dignity and respect. Of course, there's also information justice. And this is seen a lot in the workplace, where you're just not provided with appropriate information. The one that most persons reflect on is recognition and reward, which is basically obtaining appropriate money, esteem, and social control from the work you do. Now, I looked at common mental health problems in the workplace, and I choose 5. And we're going to just walk through those. And while I walk through them, I want you to do some reflection and tell yourself whether you're actually experiencing any of these. I thought it was quite interesting to note that worldwide, the commonest mental disorder, in fact, is anxiety, followed by depression, followed by alcohol use, followed by drug use, and bipolar disorder. In fact, I was a little surprised at bipolar. This is from our world data, fairly recent study, 2019. Again, the commonest mental disorder worldwide is anxiety, followed by depression, followed by bipolar disorder. Very interesting. So I decided to take a look and see what's happening in the States. Stand by, we have some data on Jamaica. The commonest anxiety, the commonest mental illness in the States is anxiety, followed by depression. Quite interesting. And bipolar disorder keeps turning up fairly often. What about Jamaica? Well, Wilkes et al. Found that 20% of respondents aged 15 to 74 had symptoms of depression. Jamaicans aged 60 and more are likely to have depressive symptoms than younger Jamaicans. Anxiety is quite common among those aged between 35 to 59. So anxiety is a major issue. I thought I'd just take a look at psychosis in Jamaica. And way back in 1995, actually, Freddie actually estimated that 2.9 per 10,000 Jamaicans were psychotic. But most of those who actually attend the mental health facility in Jamaica are due to psychosis and schizophrenia. So let us just take a look at depression. And I want us to think about this. So the individual must experience 5 or more symptoms during the same week and must show depressed mood or loss of interest or pleasure. The medical council actually insists that we incorporate mental health in CMEs, which interesting is why I'm here. So I want to go back to this. 5 or more during the same 2 weeks. So take a peek, colleagues, and tell me, if you have depressed mood most of the day, nearly every day. Markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. Significant weight loss when not dieting or weight gain, nearly every day. A slowing down of thought and a reduction of physical movement. Fatigue or loss of energy, nearly every day. Feeling of worthlessness, nearly every day. Diminished ability to think or concentrate, nearly every day. And finally, recurring thoughts of death or suicide. Just reflect on this. So depression is the mental health disorder that has been best studied in the workplace. Depression likely manifests in behaviors such as nervousness, restlessness, or irritability, and in physical complaints such as aches and pains, or the worker may become passive, withdrawn, aimless, and unproductive. They also may be tired, or they might have impaired judgment or cloudy decision making. A study from WHO has indicated that workers with depression lose up to a month per year, and 9 of them because of sick days, another 18 due to lack of productivity. How about bipolar disorder? Bipolar disorder, apparently the third commonest disorder in the States. I don't have any data on bipolar disorder in Jamaica. I'm sure it's available. You can have bipolar 1, where you have manic depressive disorder with or without psychosis. Bipolar 2, depressive and manic episodes which alternate, and cyclothymic disorder, which is brief episodes of hypomania and depression. So, in the workplace, in a manic phase, employees may appear highly energetic and creative, but productivity is low. And during full-blown mania in the workplace, the person may become self-aggrandizing or disruptive, flout workplace rules, be overly aggressive, and make decisions that are incorrect. During the depressive phase, they may display depressive symptoms, anxiety. I thought I just mentioned to you, and I want us to all reflect on this for ourselves, on our family, on our workers. The reason why I'm doing this is because when I put on my occupational health hat, I'm going to invite you to act as a supervisor and look at the performance of your employees and your colleagues and recognize if they have a particular problem so that you can make recommendation for intervention. Anxiety, as I mentioned, is the commonest mental health disorder in the world. So let us look at that in some detail. The latest data says that anxiety are associated with 3 or more of the following 6 symptoms, present for more days than not for the past 6 months. 3 or more of the following 6 symptoms: restlessness or feeling keyed up, easily tired, difficulty concentrating, irritability, muscle tension, or can't sleep, or sleep too much. So you need 3 or more. You don't just think about that. So the anxiety or symptoms therefrom can cause distress socially, occupationally, and in terms of your functioning. So at the workplace, an anxious worker might display restlessness. You might be constantly tired, don't concentrate very well, worry a lot, and they require constant reassurance. Sometimes, as with depression, the physical symptoms or irritability may be noticeable. What about attention deficit hyperactivity disorder? This is a persistent pattern of inattention or hyperactivity. So let us look at inattention. So if you notice a worker who displays difficulty paying attention to details or making careless mistakes, difficulty staying focused on task or activity, difficulty following through on instructions or completing tasks, poor organizational skills, avoidance or dislike of tasks that require sustained mental effort, forgetfulness or mistaking things, they could have a problem. What about hyperactivity? Fidgeting, squirming, difficulty sitting still, difficulty playing quietly, excessive talking or interrupting others, blurting out answers, difficulty waiting for their turn. They could be having hyperactivity. And an international review of 10 countries showed that almost 4% of employees have ADHD. And they were found to be disorganized. They did not meet deadline. They did not manage workload. They had problem following instructions, and they're constantly arguing. I'm sure you know some workers like that. And the data shows that they may lose up to almost 3 weeks per year due to ADHD. Persons with ADHD are 18 times as likely to be disciplined for misbehavior. They are 2 to 4 times likely to be terminated from a job. And the bad news about ADHD is that the treatment rates are usually low. PTSD. Well, this is really another anxiety disorder that can follow the experience or witnesses of a traumatic event. This event is usually life-threatening, such as physical or sexual assault, serious accident, natural disasters, and so on. So we need to intervene. The intervention could be primary, it could be secondary, or it could be tertiary. With primary intervention, what we need to do is put systems in place to reduce job stressors, which we have discussed. In secondary intervention, we need to modify how workers cope with stressful situations. And what we don't want is to move to tertiary intervention, which is to treat the mental disorder. So primary intervention are called organization level intervention or stress prevention. They are concerned with taking action to modify or eliminate source of stress. And the approaches that is recommended would be to redesign the work, redesign the task, establish flexible work schedule, encourage participation in decision-making, include the employee in career development, analyze work roles and establish goals, provide social support and feedback, build cohesive teams, establish fair employment policies, and share the reward. If one approaches this way, you prevent stress. Secondary level intervention is concerned with detecting and management of experienced stress. An approach that we use at the Bauxite Company, where I worked for almost 30 years, is to do a pre-employment exam, especially for workers who might be experiencing stress in a particular job. And one of the key approaches that many companies are using now is to use EQ, which is emotional quotient, where they actually evaluate your mental status for the particular task. So that can be done. You can also do periodic exam, where you evaluate the worker annually to see how they're coping and evaluate them if they've developed any mental issue. A key point here with respect to secondary intervention is for you, the supervisor, to be familiar with the symptoms and signs of mental health disorder and refer the patients for help. And finally, have I turned it off? Oh, no, I haven't. For tertiary level intervention, this is where you try and treat the stressful reaction, and many workplaces have psychologists and doctors on staff, or they establish an employee assistance program to help employees to cope with stress that has occurred. So some workplace intervention, in summary, I want to mention to you. You can intervene organizationally by improving work content, improve management commitment, ensure managers get training, improve selection and placement of workers, improve the physical and environmental characteristic, improve communication, job design, improve decision making, arrange conflict management seminars, and have proper policies and procedures. Another approach would be for those who really have been identified with problems to arrange individual psychotherapy, appropriate stress management, cognitive behavioral therapy, relaxation classes, and meditation. So, here are my final thoughts. Switch off. Whether you're working on site or remotely, it's important to strike a healthy work-life balance. That means taking regular breaks during the day and switching off your screens when your workday is over. Instead of making yourself available 24/7 to respond to work call, email, or other messages, why don't you use the time to focus on friends and family and take time to relax, recharge, and enjoy yourself? Practice relaxation techniques. Relaxing and recharging requires more than just zoning out on the couch or in front of a TV. To reduce the damaging effects of stress and protect your mental health, you need to activate your body's relaxation response. This can be done by practicing meditation, deep breathing, exercise, or yoga. Take care of yourself. Get adequate sleep, eat a healthy, nutritious diet, exercise, and you'll feel better. Remember, you can't pour from an empty cup. Take care of yourself first. Find meaning and purpose in your work. For those of you listening to me here in this hotel and online, please remember that even if you don't love your job, you can still find ways to derive meaning and purpose from the work you do. Especially healthcare providers, try to focus on how your work helps others. Look for opportunities to get more training or take job-related classes can help you find meaning in your work. So approach every day with purpose. The right attitude fuels our purpose and powers our success. Try to connect and collaborate. As human beings, we crave connection. This is my first face-to-face in 3 years. I'm sure those of you who are online will be filling up the Pegasus next time around. Develop mutually supporting relationship with your coworkers. Collaborate as a team. Have fun together to ease stress and improve your mood. If you're not close to your colleagues, make the effort to pool resources and projects. Work close together and be more social during breaks. Finally, build resiliency. The more resilient you are, the better you're able to tolerate the feelings of stress, anxiety, and hopelessness. Building resilience can also help you overcome setbacks. You do not have to be macho. Resilience is something that requires effort to build and maintain over time. That audio, sir, I would like you to play a little section of it just now. I'm going to end by let you listen to the audio I listen to almost every day to enhance my resilience and improve my mood. Please go ahead, sir. Yeah, go ahead. with the audio. Oh, you have it? Okay.
No less than trees and stars, you have
Go placidly amid the noise and haste, and remember what peace there may be in silence. As far as possible without surrender, be on good terms with all persons. Speak your truth quietly and clearly, and listen to others, even the dull and ignorant. They too have their story. Avoid loud and aggressive persons. They are vexations to the spirit. If you compare yourself with others, you may become vain and bitter, for always they will be greater and lesser persons than yourself.
Thank you, sir. Remember, you're a child of the universe, no less than the trees and the stars. You have a right to be here. Be gentle with yourselves. Thank you.
Then I promise you that we will have an exciting, fun-filled day. How was it? Okay. So we still have more time for some questions. I know, Prof, if you are so inclined, audience, you can field your questions. I understand the postprandial effects are now setting in. But nevertheless, let's push on. We have a few minutes to go. So if you have your questions, please feel free to come to the floor, or you can present them online as well. Go ahead.
All right. So, Prof, thank you so much for that presentation. I think every time you said, especially those of us in the public sector, it kind of crashed the internet that we had here. Got really busy. But we have a few questions. So, is there an approved questionnaire / checklist that can be self-administered or administered by the supervisor that in some way could help to identify individuals who are at risk of being overly anxious or depressed?
There are, but I'll yield to anyone in the audience who have training in psychiatry or psychology. I do know that there's a Zong scale that I use, especially for depression, but I must admit, I've not been actively screening my patients or my workers for mental health problem. And that is the reason why we're having this discussion. We need to start screening our patients and our workers for mental health problem, because there are screening tools that are available, but it's not being used. The one that is primarily used is for depression. But honestly, I've never seen a screening tool for anxiety, which is apparently the most common mental health problem. If there's anyone in the audience with some training in psychiatry, psychology, could respond to that? No?
What tool? Dr. Google? Okay. Oh, there's a question here about adult ADHD, which is, what are your thoughts on adult ADHD?
It's so difficult to identify, and you do need to look at the guidelines and perhaps create for yourself your own questionnaire, because the behavior is in terms of inattention or hyperactivity could be called by so many things. And so you definitely need to have a criteria in your mind to see if this particular person has just recently developed these inattentive behaviors or hyperactivity behaviors. So you're sensitized to the fact that something is wrong. The DSM-5 guidelines are fairly clear. And so what I'd suggest, especially since these are fairly common problems, is that we actually have a listing at our workplace, and if a person behaviors deviate significantly from the norm, then you just casually observe them, because in many instances, it is based on observation and see if they fit into, they at least get a number of ticks for inattention and hyperactivity, and then you refer. What I don't recommend, when I discuss this with the supervisor at Kaiser, is that they do not take on the role of a counselor or psychotherapist. Once they sense that something is wrong, then they should refer the patient to the medical provider, who will in turn will arrange for the person to be seen by a specialist in mental health. Dr. Arnold.
Yes. I was reading recently about ADHD, and they say that 60% of the youngsters diagnosed with ADHD grow with it into adulthood. And it's manifested in a number of different ways. For example, same problems with completing tasks, multitasking, interrupting with meetings. There's a whole flow of things that happens. But I also wanted to mention that we have this new illness, autism spectrum disorder. And these youngsters are now joining the workforce. It's a spectrum. So you do have those that are clearly visible, but you also have those who have been able to go through the schooling system, but still have those social problems with communication, and they can be identified at the workplace because they are loners, and they don't make a lot of relationships, and that's how they get into trouble. But that's another area, a significant area, because they say in the United States that 1 in 36 children who are being born today have autism. And it's 6 times more prevalent in boys than in girls.
Thank you, Dr. Ann. It's quite interesting that you mentioned that persons might have challenges that are not obvious, which is why we need to start thinking of doing pre-employment EQ testing, because you might perhaps be academically qualified for the task, but you might not be emotionally qualified, which is why we look at the concept of performance fit, because many persons really have specific mental issues and should be assigned to specific tasks, and they might be given a job to do for which they are not cognitively prepared, emotionally prepared, and then end up with burnout or a lot of emotional challenges. So thank you very much for that thought. I have noticed, in fact, in my own practice, that I'm seeing more children coming to me with autism, which is really a little scary. And as you said, they are going to enter the workplace, and so the time has now come for us to now really start doing emotional quotient for people to see if they're fit for the task.
Thank you so much, Doc. Doc, what about when your coworkers are against you? This is so hard to deal with, especially when you haven't done anything towards them. What can I do? It's an important question.
No,
Prof, this needs your intervention.
Yeah, it's called it's called, good question. It's called conflict management, and there are techniques for conflict management, and in most cases, the person who feels threatened by the aggressive or hostile employee really can't handle it him or herself, because they might tend to respond in like fashion. If you sense that you're being unfairly treated, by your coworker, then I think you should ask for a third party to intervene, to help to mediate between you both, because it's natural to respond to anger with anger and hostility with hostility, but that's not going to solve the problem, because it's just going to escalate perhaps to violence or to a breakdown of the relationship. So I'm thinking in this particular instance that a mediator would be useful. Prefer someone trained in mediation rather than you trying to take on a worker yourself, because they might have issues and they are transferring their frustration to you. And it's not because they necessarily dislike you, it's just because you're the most available person for them to transfer their frustration. So rather than responding in like fashion, I would suggest that you just walk them out and get someone to mediate.
Thank you so much, Prof. And the final question is a statement. Excellent presentation. Please do it more often. Cheers.
Thank you.
Everyone,
Thank
please give Prof a round of applause. And before I hand back over to Nakia, a few housekeepings. Please remember, for those in the room here at the hotel, on the screen is where you register. If you've done so already, thank you. If you've not done so yet, please go ahead and register so that we can ensure you get your CMEs today. Those who are on YouTube, in the chat, you have your registration. And those on Zoom, you're already registered. You don't have to request your CMEs. Nakia, over to you.
Thank you, Sam. Of course, a good meeting requires a very good closure. And so we're going to give a vote of thanks, and we're just going to re-invite Dr. Arnold J. Brown Morgan, who is a representative from the AGPJ, to do us the honors. Please.
Well, it is my honor and pleasure to give the vote of thanks on behalf of the Association of General Practitioners of Jamaica. We have shared an interesting knowledge-filled morning and afternoon where we have benefited significantly from all our speakers, Dr. Kevin Harvey, Dr. Soyibo, Dr. Dwayne Hall, and Professor Alverston Bailey. It is my great pleasure to thank them all for so graciously spending the day with us. We learned a lot. It falls also to me to thank the various officials who participated in various roles today. So I thank the following people. Ms. Christian Clark for her welcome and prayer earlier today, and of course, Ms. Pitkin, is it? Sonia, Mrs. Soyibo, Miss Sonia Pitkin, Sana Pitkin for her her introduction to Dr. Dwayne Hall. I had her down originally a bit earlier, but Ms. Christian Clark fitted in. Our president of the Association of General Practitioners of Jamaica, Dr. Donald Gordon, we thank him for his welcome to us all earlier today. And our thanks to Mr. Christian Frater for his introduction of Dr. Harvey, and Mr. Shane Francis for her introduction of Dr. Soyibo. Many thanks to Mr. Nakia Rowe for serving as our moderator for the entire day. Very, very well done, Nakia. At this time, it is also with deep gratitude that I thank Sandoz for providing us with this opportunity to hold this healthcare summit in hybrid format, online and at this lovely hotel, at the Jamaica Pegasus Hotel. I take this opportunity to thank the hotel staff for their care of us today. Then, of course, I must thank the planner extraordinaire, Executive Administrator, Mrs. Lynn Thompson Hyatt, from the AGPJ, Association of General Practitioners, for the very hard work she participated in making this event happen. And thanks to Sam. Sam? Our eloquent, hardworking, online IT, making it happen, gentlemen. So, thank you. And finally, thanks to all the participants here and online. It's been a long day, but it has passed quickly because of the quality of the material our lecturers today, our presenters shared with us. So thank you for being here in reality. Thank you for being here out there in the stratosphere online. It's all about you. So thank you very much. Please relax, recover, and enjoy the remainder of your Sunday.
Thank you, Dr. Brown-Morgan. So I'm just going to close the meeting. Just a few final words from myself and on behalf of Sandoz. And of course, you can all agree that today was a day well spent, right? Agree? Let's hear another round of applause. We did cover a lot of material in a very short time. You know, we were able to keep time and we were able to ensure that you are able to go home, and if you so desire to partake in another course, you can do so. Also, you know, these Sandoz meetings and summits are very, very dear to us. Today served also as a relaunch of our Zinat brand. So we are excited, we're pumped, we're ready to come out there in the field and share more on Zinat for you guys. So look out for us, we're coming. So again, I want to thank everyone for coming out. But you know, technology has really allowed us, I guess since COVID, to be able to have this sort of blended hybrid sort of arrangement. And persons at home, I know you somewhat feel a little bit cheated by not getting a meal, but as Prof said, hopefully next time you will fill the room. I will see more. And of course, for those who are in attendance, it is always good to come out so that we can see your shining faces and we are able to meet again to remember what you actually look like. And I say that because, you know, remember, wearing the mask, sometimes you cannot forget what people look like. Has anybody has that challenge? So I'm happy that we're able to do this forum. So again, thank you for coming and thank you for everyone. Please get home safely, drive safely, and have a good rest of the day. Thank you all.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotic site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundal facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundal. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zinat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotics site is Kundal, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundal facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
As Sandoz is the spiritual home of antibiotics, we are proud of 1. Being the global leader. 2. Having presence in the market for 75 years. 3. Covering 50% of the world's available antibiotics. 4. Having presence in more than 100 countries. 5. Producing 300 million treatment packages annually. 6. Having the highest quality standards. 7. Our global production center at Kundal. Our goal is to maintain our leadership, and we're always searching to improve the quality of life of our patients. Today, we are proud to share with you that we're expanding our portfolio with the addition of Zenat, the molecule in which you already trust, and now it comes with the support and quality of Sandoz. We want to thank you for your support and to invite you to keep being an essential part of the evolution and growth of Sandoz.